Respected seniors and dear friends, a very good afternoon and a warm welcome to the National Virtual Grand Anemia Conclave. It has been exactly 50 years since Anemia Control Program was launched by Government of India. Yet, India carries the highest burden in the global scenario. As per NFHS data of 2016, 50.4% of our pregnant women still suffer from anemia. It is so common that even we have accepted it as a norm. Seeing the enormity of this situation, a focused Anemia Mukt program has been launched by the Government of India. So, the Safe Motherhood Committee decided to test, treat, and talk anemia through this mega conclave. I welcome our dignitaries, FOGSI President, Dr. Alpesh Gandhi sir, Secretary General Dr. Jaideep Tang sir, Vice President Dr. Atul Ganatra sir, under whose guidance Safe Motherhood Committee has been working, National Advisor Dr. Chandravati ma'am, and the torch bearer of this committee, Dr. Preeti Kumar. We also have amongst us FOGSI President 2013, Dr. Hema Divakar ma'am, eminent FOGSians, Dr. Meera Agnihotri madam, Dr. Sampath ma'am, and many stalwarts as senior faculty today. Welcome all once again. Today, friends, we are going to talk about the diagnostics aspects of anemia. And in the continuum of this conclave on 30th, that is just after 2 days, management of anemia will be taken up. See, mission of this caliber is not possible without many helping hands. FOGSI ICOG office has granted 2 credit points to this conclave. So do attend on both the days. And thank you, Lupin, for being our academic partner. I now invite Dr. Preeti Kumar, Chairperson, Safe Motherhood Committee. As you can see, not only Mega AICOG 2020, but practically every year she's organized one conference. She has many scientific feat to her credit. I request you, ma'am, to welcome our delegates and guests.
Thank you, Meera. Welcome all to this National Virtual Grand Anemia Conclave, an initiative by FOGSI and Safe Motherhood Committee, FOGSI, and the mission is to make every mother and newborn safe. As Meera has rightly said, that Anemia Mukt Bharat is a dream, but it has to come into reality one day. The road to success has many challenges, but today FOGSI and Safe Motherhood Committee has taken a pledge towards MA, that is March Against Anemia. With this vision, this conclave will address the issues of diagnosis and management, as already mentioned, and Safe Motherhood Committee expresses the gratitude to FOGSI leaders, especially Dr. Alpesh Gandhi ji, for supporting this mission. I warmly welcome you, sir, on this forum. I also welcome my teachers, especially Dr. Chandravati madam and Dr. Meera Agnihotri ji, and all my faculties and delegates for joining today. We are blessed to have the virtual presence of Honorable Deputy CM Shri Keshav Prasad Maurya ji for the inaugural ceremony as chief guest and for this program. Thank you so much, sir, for your blessings. Now let us all join hands and raise our voice against anemia. It's a high time we need to again test, treat, and talk anemia. Thank you so much, Lupin, for supporting this endeavor. And thank you all once again. Thank you, Meera. Now you can proceed.
Thank you, Dee. It is indeed your hard work and commitment that we are able to see so many innovative programs almost every week and every month. I request President Sir, Dr. Alpesh Gandhi Sir, along with all the dignitaries to light the symbolic inaugural lamp. Let us all pray to Goddess Saraswati to grant us knowledge for the benefit of all. Blessings of elders is a caveat for success of any program. I request respected Chandravati ma'am, past president UPCOG and Lucknow Society, national advisor to the committee, to say a few words and give her blessings.
Thank you, Megha, and thank you, Preeti, everyone. It's a pleasure to be present here for the inaugural function of this Grand Anemia Conclave, which is going to deal with the diagnosis and management in 2 sessions. On my behalf, as Preeti has already welcomed each faculty and welcome all the delegates to this Grand Conclave. We all know that anemia almost affects 2/3 of the pregnant women, leading to high-grade maternal mortality, morbidity, and as well as neonatal morbidity and mortality, and also morbidity into the neonatal period and infantile period. Even WHO has said that in developing countries, almost about on the average of 56% women, and in the industrialized cities of what in developing countries about 80% women still suffer from pregnancy anemia. The problem is that many of them start pregnancy at a negative node, at the negative node of iron, and they start anemia, anemic pregnant women, and this goes on to a higher level when they become pregnant. It has been found that anemia, in fact, is a health problem which needs to be tackled at an earliest. And where do we start? We start from the newborns who should not be born with a negative iron stores. We need to look after the adolescent and the young girls who should not be on a minus level of iron when they get married and get pregnant. And we need to look into the pregnant, expecting women, pregnant women, that they should not be pregnant with a negative node. Various projects, programs have been run so far, but somehow we have not been successful in tackling this such an important condition which could be cured. There are multiple aspects of it. There are nutritional deficiencies, there are causes of worm infestations. There could be an increased need during the pregnancy, and we are unable to supplement them. All those programs where anemia is being provided from the national level as a government program, somehow the compliance is not good. And at this era also in 2020, we still get severely anemic women when they're expecting. So friends, this 2 days conclave is a wonderful conclave where you need to know about the diagnosis, because it is very important to know the type of anemia, carefully you can tackle it. And then it is important to know the time, because without that you cannot do the management. So I'm happy those of you who have logged in today, and I request you to log in on 30th also, because Dr. Preeti, the chairperson of the Safe Motherhood Committee, along with her all workers and helpers and all the faculty which is involved in helping and arranging this conclave, would be very happy with the large number of people getting advantage of these 2 days conclave. I wish this conclave a great success, and thank you, Meera, for inviting me to say a few words. Thank you.
Thank you, ma'am, for those insightful words. Your blessings are needed for every program and every step of the way. Now, I would invite the head of the FOGSI family, Dr. Alpesh Gandhi, sir. Sir, it is an honor to introduce you. Among all the prestigious posts, he has been the Vice President 2013. He has been Governing Council member of ICOG, Chairperson Practical Obstetrics Committee, and above all, despite this pandemic limitation, FOGSI is continuously doing the tremendous work under your leadership, sir. I request you, sir, to say a few words to all the delegates and many, many guests who have logged in today. Thank you, sir. Dr. Alpesh Gandhi, sir.
Thank you, Dr. Meera, for the kind words, generous introduction. Dr. Chandravati Madam, always inspirational to all of us. Dr. Meera ji, teachers of the teachers. Dr. Preeti Kumar, Chairperson, Safe Motherhood Committee. Dr. Atul Ganatra, always guiding Vice President to Safe Motherhood Committee. Dynamic Secretary, General FOGSI, always very cooperative to all the committees and all of us, Dr. Jaideep Tak. All the esteemed faculties, FOGSI and ICOG office bearers, and dear friends. A very good afternoon to all of you. I extend warm welcome to all of you on behalf of FOGSI. And at the beginning, I would like to congratulate Dr. Preeti Kumar, Chairperson of Safe Motherhood Committee. She is very active. We all know that. There is no need to describe which are the programs she is conducting, but we can see she is not allowing anybody else to take rest. We can see a good impactful programs, a good gathering, good take-home messages. She is very hardworking, and I am fortunate to have Preeti Kumar as the committee chairperson of Safe Motherhood Committee with me at FOGSI. Thank you, Preeti ji, and thank you to all the team members of Safe Motherhood Committee. At the beginning, I would also like to thank Deputy Chief Minister Sri Kesav Prasad Maurya ji for accepting our invitation to be the chief guest of this Grand Anemia Conclave, a very important program for us. In his busy schedule, he became ready to give his video message for all of us. Thank you, sir, for your kind gesture, blessings, and message. In next 7 to 8 minutes, I am going to speak on FOGSI's mission, FOGSI's vision for anemia. We cannot have a fragmented vision. FOGSI's vision is anemia-free India, which is also the mission vision for Government of India. As Dr. Meera has just mentioned, since 50 years we are trying to eradicate anemia from our country. And because of some of the reasons, still we are facing, of course we have improved a lot, but still we are facing some problems. Our country is celebrating 151st birth anniversary of Mahatma Gandhi ji, and we all FOGSians believe in his message, the best way to find yourself is to lose yourself in the service of others. And we also believe, FOGSI 2020 also believes in Steve Jobs' declaration, if you are working on something exciting that you really care about, you don't have to be pushed. The vision pulls you. And we can see this year, FOGSI members, in spite of with this very difficult situation of COVID-19, we all are so active in different, not only in academic programs, but in community connect programs and in so many social programs also. The theme for this year is Safety First for Indian women and FOGSians, and we cannot imagine safety of Indian women without treating anemia. We believe that we are safe when our patients are safe. Our patients are safe when we are safe. And we envision that safe motherhood is a woman's legitimate right. Saving a mother's life should be a cohesive national responsibility and utmost priority. In this time of COVID-19 pandemic, let me for a moment direct your attention towards the non-COVID endemic that prevails in India, that is anemia. Anemia is the most common nutritional disorder across the world, but in India, we are affected a lot. Anemia is widespread in India, 58.6% of children, 56% of adolescent girls, 53.2% of non-pregnant women, and 52.4% of pregnant women were found to be anemic in 2016 as per the NFSHS. This amounts to an average 64 million girls at any point in time are anemic in our country. 52.4 pregnant women are anemic means 14.15 million pregnant women are anemic in India at any given point of time. And major risk factors identified, as Dr. Chandravati Madam has mentioned: nutritional deficiency, socioeconomic status, blood loss during menstruation, hand hygiene, worm infestation, and many others. But one of the most important is still lack of awareness, lack of sensitization, and lack of dedication to eradicate anemia. In a routine blood test, anemia is reported as a low hemoglobin. Hemoglobin is the main protein in our red blood cells. It carries oxygen, delivers it through the body, and ensure adequate tissue oxygenation. A sufficient hemoglobin level must be maintained. Our normal hemoglobin level, we all know, for females, it is 12 to 16. If there is low hemoglobin level, the tissue oxygenation will not be proper and organs may not function properly. The signs of anemia can be so mild at the beginning that women may not even notice them. But if the condition gets worse, women may develop many other symptoms. Anemia causes adverse consequences as the disease progresses. It not only affects the overall growth, but also affects the overall health and performance. Their attentiveness, memory, school performance, retention in school, school attendance, onset of menarche, affects immune system leading to infections and can cause so many other complications. If the anemic adolescent girl becomes pregnant, it may increase overall maternal and fetal morbidity and mortality. Severe or untreated iron deficiency anemia during pregnancy can increase the risk of preterm delivery, low birth weight baby, a baby with anemia, a child may have developmental delays and may have neural tube defects because of some deficiency. and she may develop postpartum hemorrhage, she may require blood transfusion, she may have postpartum depression, she may have difficulty in breastfeeding, and it is said that anemia is responsible for 20 to 40% of maternal mortality rate directly or indirectly. So it ultimately adds fuel to all the possible complications of pregnancy and make it severe. And that is why today world has decided to use 26th November for the World Iron Deficiency Anemia Day to eradicate iron deficiency anemia from the world. At the same time, beta thalassemia is the most common single gene disorder in our country. 30 million carry the defective gene and over 9,000 thalassemic babies are born every year. Treatment is expensive with high mortality morbidity, and it is simple because now we advise antenatal profile to all our pregnant women, which includes CBC, read hemoglobin and red cell indices properly, give 30 seconds to these values. If MCV is less than 78, if MCH is less than 27, it is highly suggestive of possibility of presence of thalassemia trait. Sensitivity specificity is high. In such case, we should ask test for thalassemia for mother. If she is found positive, we should ask test for from her husband. And if he is also found to be a carrier, then do proper genetic counseling, offer them prenatal diagnosis, and if required, selective termination can be done. And this way we can also eradicate thalassemia major from our country, which is also one important cause at some of the places. Thalassemia and sickle cell anemia are again two important causes. Similarly, it is also advisable to ask for PT, APTT and platelet count before any planned obstetric surgery. We may come to know unknown conditions and can prevent a few life-threatening complications. FOGSI has recently conducted 2 opinion polls, a very simple polls. Do you believe hemoglobin should be more than 12? And 88.46% of our members replied yes, it should always be more than 12 during pregnancy. This is regarding pregnancy. And the incidence of anemia in USA is only 6%, and in India it is more than 50%. Do you think we all can jointly make India nearly anemia-free India till 2025? And our members have very positive reply. They all believe that yes, if we all can decide, if we all can work unitedly and with positive planning, yes, we can. 95.56% of our members believe that yes, we can make India anemia-free India in next 5 years. So we all decide to work for it unitedly, and we need to make some planning for next 5 years, how we can eradicate anemia from our country. And most important is mass awareness. Today, if you ask any person on the street about COVID, he will tell you everything, how it spreads, what harm it does, and how you can prevent it. How has this happened? In a single word, simple word, awareness. People have been given this information repeatedly through various media channels, and that is why we all know about it. And that is all we need to do for anemia as well. Like COVID is associated with mask, anemia should be associated with hemoglobin, and hemoglobin more than 12. Let us take the first step towards the dream of anemia-free India, which is the biggest public health issue. Let us take first step towards an anemia-free India by getting our CBC test done. Let HB always be more than 12, and let this awareness to be created across India as a wave. Like at present, we all have awareness regarding COVID-19. Women from every walk of life are affected by anemia. However, our goal should always be that we stay more than 12 if we eat enough and if we eat proper items. For the first time in the history of independent India, more than 38,000 FOGSians have come together to spread the word for anemia-free India. Let us take this great initiative to the next level by making everyone aware about hemoglobin should always be more than 12. And I am sure a Safe Motherhood Committee of FOGSI is working very hard. They will definitely make some further programs and plans for the awareness of our citizens of India, our mothers, our adolescent girls, how they can be make aware and how we can achieve. Yes, of course, and that is why here the slogan is also taste, treat and talk. Talk means counseling, talking and making them aware about the importance of hemoglobin. Getting your CBC test done, know your hemoglobin is the first step. And if hemoglobin is less than 12, eat enough food, eat the right food, consult your doctor for the further investigations, identify the cause, take the drugs and remedies prescribed by FOGSI members. Once Sardar Patel has mentioned that manpower without unity is not a strength. Unless it is harmonized and united properly, then it becomes a spiritual power. For strong unity and solidarity, we will work for increasing strength by encouraging non-FOGSI gynecs also to join FOGSI during this year for such causes, and we are doing this for our community connect programs. So let us work all together to make India anemia free India. And this year also we have seen one vision. Each society adopts a PSC for safer pregnancy. But unfortunately, because of COVID-19, we could not go ahead in this project. But as we all know, our Honorable Prime Minister has launched a Pradhan Mantri, already a scheme is there where every month on 9th of the on the 9th we are taking care of, many of our FOGSI members are taking care of a PHC center or CSC center or wellness center where they are going and examining patient. So similar program we also want that we are once COVID is over, we would like to adapt 250 societies, adapt at least a one PHC center where obstetricians are not available, and our willing FOGSians will visit PHC twice a month and will do antenatal checkup, advise antenatal profile, prescribed required medicines and nutritional care, identify high-risk patients like severe anemic patient, and refer them to higher centers for further care. So these are the basic intention. Anemia is a preventable disease, and let us work. We should see that it should not be, any women should not die from a disease which is completely preventable. And I see at the end, I would like to say, I foresee FOGSI 2020 is to plan and to start work to achieve SDG goal. We have to achieve SDG by 2030, but we should try to achieve it by 2025, and many things are doable. I believe that, and we should plan accordingly by setting and working for our own targets. We should have our own targets like hospital delivery rate, which is now at present 90% to 100%, MMR 67 by 2025 instead of 23, and 6-7 states already in India have achieved. NMR 25 by 2025, already in 4-5 states it has been achieved. Safe abortion 0% mortality because of abortion by 2025, and again all for MMR, NMR, safe abortion, 0% mortality. For all this, important thing is antenatal booking and screening by antenatal profile in the first trimester at the as early as possible in 100% of pregnant women, so that we can identify anemia or any other complications or diseases in the first trimester at the earliest, and we can try hemoglobin more than 12 for all before pregnancy by the age of 15, and if not, if even though some reaches to the pregnancy without 12% of hemoglobin, then we can identify during the first trimester itself, and then we can take required care. And let us also work together for the thalassemia eradication from India. of course. So these are the targets we should set for us. What I have seen in FOGSI is that we have very good mission, but we also require some targets like SDG. Previously, our country has 5-year planning commission. Now we have Niti Aayog. Similarly, we should also have our targets, and we have a very good liaison with next incoming president, Dr. Santa Kumari and Rishikesh Pai. We all can sit together to make a roadmap for the next 5 years, and we can work together for these targets. And this is how we can eradicate anemia from our country. Thank you very much for giving me this opportunity, and I wish grand success to this 2 days webinar. And I am thankful to Priti Kumar, Safe Motherhood Committee, and all of you for giving me this opportunity. Thank you.
Thank you so much, sir.
Thank you, sir, for your elaborate discussion and your vision for anemia control in India. Definitely, if you all join hands, we can control this situation. So we quickly move on, and we are now going to play the video message of our chief guest, Honorable Deputy Chief Minister Uttar Pradesh, Shri Keshav Prasad Maurya ji. We are thankful to him for giving us his valuable time and acknowledging the efforts done by Safe Motherhood Committee.
ग्रांड एनीमिया कंक्लेव जैसा कि कोरोना काल में वर्चुअल तरीके से आयोजन किए जाते हैं, और उसी के क्रम में जो आज यह कार्यक्रम यहाँ पर संपन्न हो रहा है, पहले तो मैं सभी आयोजकों को ऐसे महत्वपूर्ण कार्यक्रम के आयोजन के लिए शुभकामना देता हूँ, बधाई देता हूँ। विशेष तौर से डॉक्टर अल्पेश गांधी जी और डॉक्टर प्रीति जी और उनकी पूरी टीम को। आप सभी को विदित है, देश के यशस्वी प्रधानमंत्री माननीय श्री नरेंद्र मोदी जी, विशेष तौर से हमारे देश के अंदर जो हमारी गर्भवती माताएं बहनें हैं, उन सबके स्वास्थ्य के निदान को लेकर के एक संकल्प लिया है, और उसी संकल्प के क्रम में प्रत्येक माह की 9 तारीख को महिलाओं को सरकारी हो चाहे निजी चिकित्सा हो, वहां पर उनके स्वास्थ्य परीक्षण की व्यवस्था की गई है। गर्भवती महिलाओं में एनीमिया की वजह से उनके बच्चे और उनको कई बार जान का खतरा भी हो जाता है। केंद्र की सरकार माननीय नरेंद्र मोदी जी के नेतृत्व में लगातार इस दिशा में प्रयास कर रही है, और उसी क्रम में उत्तर प्रदेश की सरकार भी इस अभियान को आगे बढ़ाने का काम कर रही है। गर्भवती महिलाओं में एनीमिया का मुख्य कारण शरीर में आयरन की कमी है। इस संदर्भ में 26 नवंबर को वर्ल्ड आयरन डिफिशियंसी डे भी एनीमिया की प्रति जागरूकता बढ़ाने के लिए मनाया जाता है। 26 नवंबर महत्वपूर्ण तिथि है। भारत सरकार का एनीमिया मुक्त भारत अभियान भी इसी कड़ी में एक प्रयास है। यह अत्यंत हर्ष का विषय है कि फॉक्सी एवं सेफ मदरहुड कमेटी फॉक्सी 2 दिवसीय ग्रांड एनीमिया कॉन्क्लेव का आयोजन कर रही है, जिसमें देश भर के नामचीन विशेषज्ञ गर्भवती महिलाओं में एनीमिया के कारण निदान एवं इलाज पर विस्तृत रूप से चर्चा करेंगे, और उस चर्चा के परिणाम निश्चित तौर से हमारे देश की सभी मातृशक्ति को प्राप्त होगा। इस ग्रांड एनीमिया कॉन्क्लेव के सफल आयोजन के लिए फ्रांसीसी प्रेसिडेंट डॉक्टर अल्पेश गांधी जी, डॉक्टर प्रीति कुमार जी जो चेयरपर्सन हैं, सेफ मदरहुड कमेटी फॉक्सी को मेरी तरफ से हार्दिक शुभकामनाएं हैं। मैं आशा करता हूं कि भविष्य में गर्भवती महिलाओं के स्वास्थ्य से जुड़ी समस्याओं पर फॉक्सी एवं सेफ मदरहुड कमेटी चेयरपर्सन डॉक्टर प्रीति कुमार जी इस तरह के कार्यक्रम आयोजित करती रहेंगी। मुझे पूर्व में भी आपके द्वारा आयोजित कार्यक्रम में सहभाग करने का मौका मिला, और वह कार्यक्रम भी बड़ा यशस्वी और बहुत सफल रहा है। मैं उत्तर प्रदेश सरकार एवं भारत सरकार के द्वारा प्रधानमंत्री सुरक्षित मातृत्व योजना में अपना योगदान जो है उसे जारी रखने का जो संकल्प है उसको हम लोग सफल बनाने के लिए निरंतर लगे हुए हैं, और इस प्रकार का आयोजन निश्चित तौर से देश के लिए भी और प्रदेश के लिए भी और एक तरह से दुनिया के लिए भी अत्यधिक महत्वपूर्ण होता है। कोविड-19 के कारण से आज का यह कार्यक्रम निश्चित तौर से उद्घाटन सत्र में आपने मुझे आमंत्रित किया है, लेकिन कोविड के कारण प्रत्यक्ष उपस्थित होने की जगह या वीडियो संदेश के माध्यम से ही मैं आप सब के प्रयास की हृदय से सराहना करता हूं और आप सबका प्रयास निरंतर यशस्वी रहे, सफल रहे और इस देश की मातृशक्ति को जो समस्याएं हैं गर्भ धारण करने के पश्चात की, उस समस्या से निदान पा सके। यही मेरी शुभकामना, यही मेरी मंगल कामना। बहुत बहुत धन्यवाद।
Thank you, sir, for your kind words. Now I invite Dr. Atul Ganatra, sir, as chairperson for the first session. Sir is Vice President FOGSI 2020-21, Treasurer IAGE, Chairperson MTP Committee FOGSI 2012-2014, Member Managing Committee MOGS, Director Ganatra Nursing Home. Safe Motherhood Committee is working under his guidance, and we are blessed to have sir as our mentor. Our next chairperson is Dr. Neerja Batla, ma'am. Dr. Neerja Batla is Professor and Unit Head Department of Ops and Gynae, AIMS, New Delhi. Ma'am is Secretary General, International Federation for Cervical Pathology and Colposcopy. Past Chairperson, FIGO and FOGSI Gynae Oncology Committee. Past President, AOIGN and Founder President, AOGIN India. Ma'am has authorized more than 250 articles in national and international journals and has presented over 700 lectures in national and in international conferences and CME. Ma'am, we welcome you, Dr. Neerja, ma'am. Our third chairperson is Dr. S.P. Jaiswal, ma'am. Ma'am is very active member of LOCS and Safe Motherhood Committee. She is Professor and Unit Head Department of Ops and Gynae, KGMU, Lucknow. Visiting Professor at BP Koiraila Institute at Nepal. Ma'am has published more than 80 international and national publications. Now I will request Dr. Atul Ganatra, sir, to invite our distinguished speakers. Dr. Atul Ganatra, sir.
Good afternoon, and thank you, Dr. Preeti Kumar, Dr. Alpesh Gandhi, and the entire Safe Motherhood Committee. I have always said Dr. Preeti Kumar is world famous in India. And it's an honor and privilege to invite my dear friend, Dr. Jaideep Tank. I don't think I need to read his CV, but it's a very, very long CV. He's the Secretary General of FOGSI. One of the better administrative officers that I have ever come across. When Jaideep was president of MOGS, he was probably a member of all the gynec associations in the world, whether it was FIGO, SAFOG, AOFOG. And of course, he's a very dear friend, my IVF guru, and hopefully will be the forthcoming president of FOGSI, Dr. Jaideep Tank.
Thank you very much, Atul, for that very kind and generous introduction. I hope my slides are seen.
Yes, sir. Yes, sir.
Yes, thank you. So let me first begin by congratulating our dynamic president, Dr. Alpesh Gandhi, Vice President, Dr. Atul Ganatra, the chair of the Safe Motherhood Committee, Dr. Preeti Kumar, and of course, the national mentor for the Safe Motherhood Committee, our own Chandravati Madam, and the entire team of the Safe Motherhood Committee for all the wonderful work that they have been doing. Thank you, Atul, for that very kind and generous introduction, and also to the chairpersons, Dr. Jaiswal and Neerja. I will try and keep this presentation as brief as possible, and I believe that the brief of the presentation essentially is to lay the context, if you will, about why the burden of anemia in pregnancy indeed is a strain both on our maternal health and on the supply side, the healthcare system of our country. So this is the overview of the presentation. I understand that there might be some repetition from what has already been said and what is to come in the next few presentations. And therefore, as I said, Without skipping over important facts, I will try to minimize repetition. We have literally grown up as medical students, residents, and now practicing doctors with the definition of anemia, which is essentially linked with a hemoglobin concentration of less than 11 or less than 12 in pregnant and non-pregnant and lactating women. This is a fairly well-known classification to define the severity of anemia. And if you look at this slide, for me personally, it is a rather telling sign that although the WHO stops at defining anemia at less than 7 grams, ICMR has actually put in one more category that is very severe at less than 4 grams per dl. And I believe that one of the reasons why the ICMR has done that is because although anemia in pregnancy is a major public issue throughout the world, it is more so in the developing countries, where it is an important contributor to maternal morbidity and mortality. The prevalence, as has been well documented, of anemia in pregnancy is highest in Southeast Asia, followed by Africa, which is quite well illustrated in this graph over here, taken from a WHO publication. Much like so many other well-meaning policies developed and even rolled out by the government, anemia has also not been lacking attention. We've had the National Nutritional Anemia Prophylaxis Program, we have the NACP, we have the NIPI guidelines, and yet we find that over half of all pregnant women in our country suffer from one form or another of anemia. In fact, some authors have attributed 50% of global maternal deaths to anemia, and 80% of these global maternal deaths due to anemia apparently occur in India. Although the prevalence of anemia in India has decreased marginally, the numbers are still very, very large. It's quite odd to see that the highest prevalence of anemia, if you look at it state-wise, does not really seem to correlate with the other social, economic, or health indicators in various states. Some of the states where the incidence and prevalence of anemia is highest are otherwise quite well-developed states. Anemia in pregnancy obviously increases as the patient undergoes the pregnancy and then has a lactation, as you will see in this time trend slide. The question we need to ask ourselves really, with all the policies, etc., that have been in existence, is how have iron and folic acid interventions fared? Because at the end of the day, if we are looking to scale public health interventions, then food interventions have to be something which we need to consider. The fact of the matter is, not very well. This may be either due to the problems with the delivery of well-meaning initiatives or a gap in the initiative itself. But IFA intervention does appear to be ineffective in India. Again, the reasons for this can be debated. Is it due to a lack of delivery? Is it due to a lack of last mile outreach? Is it due to a lack of compliance, or is there a problem with the way the entire structure of the program is designed? The fact of the matter remains that from 2006 to 2016 in India, anemia declined but still is highly prevalent. The key drivers of anemia reduction for children were improved health and nutrition interventions, and for pregnant women, were improved education and wealth. Barriers to progress, as I said, included low coverage of interventions during pregnancy and early childhood, vegetarian diets, illiteracy, and poor sanitation. So to reiterate, India is probably a high prevalence region for various reasons ranging from eating habits to early onset childbearing to hookworm infestations to deficiency of anemia in soil and even hemoglobinopathies. I understand that there is a presentation later on the diagnosis, etc. But very briefly, anemias are either acquired or inherited, but by far the most common cause of anemia is nutritional, either iron deficiency, folic acid, or vitamin B12 deficiency. There is, of course, the fact that there is a clinical entity known as physiological anemia of pregnancy, where essentially what happens is that the plasma volume expansion is much more than the expansion of the red cell mass, which leads to normocytic normochromic anemia. Of course, there are certain advantages also to this happening. This reduces blood viscosity, increases placental perfusion, increases fetal oxygenation, and can act as a protective buffer against blood loss in third stage. However, there is no doubt that this physiological anemia of pregnancy compounds nutritional anemias in pregnancy. This is, of course, the interplay of various factors which essentially lead to an imbalance between the demand and supply of micronutrients along with blood loss, which results in all the problems of nutritional anemia. Folate deficiency remains the most common cause of megaloblastic anemia in pregnancy, and vitamin B12 is also a fairly important cause. We know that there are severe repercussions of anemia for the mother. As I said, anemia has been attributed to various kinds of adverse pregnancy outcomes like maternal transfusion, sepsis, cesarean delivery, and even later cardiovascular disease. Amongst the problems and consequences of anemia in the mothers are antenatal complications ranging from preterm birth to heart failure to infections, intrapartum complications like fetal distress, increased risk of operative interventions and heart failure, and postpartum complications like PPH, pulmonary thromboembolism, and heart failure. But anemia does not stop having its devastating effect with the mother alone. There is fair amount of evidence to show that anemia also has consequences on the fetus by virtue of the fact that there's a correlation between anemia and preterm birth. This automatically leads to fetus being born with low birth weight and SG and neonates. And also there are some studies which document long-term effects of anemia in pregnancy due to various kinds of neurological deficiencies. So the consequences of anemia for the fetus could range from low birth weight, prematurity, congenital anomalies, and to even abnormal cognitive development in the long term. But I'd like to put a macro view of the problem of the burden of anemia in pregnancy here and introduce the concept of CTC or total ownership cost, which is prevalent in a lot of corporates in our country. CTC is cost to company and TOC is total ownership cost. These are economic models which are used to look at the morbidity problem or the burden problem in its entirety. So just think about the way anemia affects mothers and the fetus. And because of all these effects, think about the strain which anemia places on our health systems in terms of morbidities, the human resource and infrastructure which has to be devoted to taking care of those morbidities, and you will realize that actually the burden of anemia is perhaps not limited only to pregnancy, but has a much more profound effect both on the economics of delivering healthcare and personally to the mothers who suffer from it. So let me conclude by saying that tackling anemia in India requires investment in women's education and socioeconomic status, along with a continued focus on improving health and nutrition, besides plain and simple medical intervention. Thank you very much.
Are you there? Thank you, sir, for those wonderful presentation. And now I request Dr. Nirja Batla ma'am to introduce Dr. Girjawal madam. Next speaker.
Thank you, Dr. Meera. Thank you for this invitation to be here at this magnificent conclave today. Really, really so heartening to see so many stalwarts and so many delegates. Excellent conclave. And it is my proud privilege also to introduce Dr. Girija Wagh. She is well known to everyone. I'm not sure she needs any introduction, but I will inform still that she is the professor of obstetrics and gynae at Bharatiya Vidyapeeth in Pune, and also a consultant at Cloud9, director of Girija Hospital. And she has many, many accomplishments and many awards, and a dedicated FOGSI member. She has the Trupta Umranikar Award from her MD days, Excellence in Medical Service, Anandibai Joshi, the specializations she has in fetal medicine and gynae endoscopy. She has been a member of the steering committee in the World Organization of Gestosis and the vice president of the India Gestosis and the assistant coordinator of the National Eclampsia Registry and the chairman person in the Medical Disorders in Pregnancy Committee, the joint secretary in FOGSI in 2010, and a national mentor for Lakshya. This is just few of her achievements. So I just don't want to stand in the way. I invite Dr. Girija Wagh to give us her excellent presentation.
Hello, everybody. Good evening. And at the outset, I want to seek blessings from Madam Chandravati, who's always been behind such wonderful acts. And Preeti, congratulations for getting around the entire country with so much of great attendance to this particular conclave, and especially Dr. Alpesh Gandhi for showing us a holistic way ahead. And Jaideep always is very, very precise on the time. So with respect to chairpersons, I will not waste more time, and I'll go ahead with the module that has been attributed to me about clinical diagnosis of anemia in pregnancy. Much has already been spoken in the overview by Dr. Jaideep, and we all are well aware of the essentials of the iron physiology, absorption, and what is very important is to be able to make a proper kind of a clinical diagnosis, because what we are depending on commonly to look at anemia is looking at the hemoglobin level. In many parts of our country, we still only do the hemoglobin level. Much can be done by looking at the complete blood count. And the only hemoglobin that we look at is actually an iceberg in itself, because it just tells us the oxygen carrying capacity, which is the definition of anemia. But there is a lot below down there. And that is something that we have to look in whenever we are looking at anemia. So we all know that anemia is extremely rampant and common in our pregnancy for various reasons, from worm infestations to poor eating habits, or just by the increased metabolism and the cellular shedding. And this keeps on increasing throughout the trimesters. And this is something that requires to be reiterated again and again, because even in our clinical practices, we have to be extremely conscientious about the way we prescribe iron. So we have to take this into account, whether we are prescribing it rightly and whether the woman is compliant correctly or not, because there are wonderful studies which have shown how is the iron sort of a gain and loss maintained during pregnancy. And this is a wonderful chart which we can just take a screenshot and keep it always ready to understand that we require to overcome this particular iron investment during pregnancy. And this is because we have to ensure that there is a proper perfusion to the placenta and the fetus. Now, iron physiology has been quite complex, and there are quite a few things which are yet not overt, and these are something that we require to still find out. But there are a few important things which have been understood very well, and one is that the iron gets absorbed from the gut. Two, ferritin happens to be a better identifier of the iron deficiency, and there are so many other things as practitioners that we know that it can get combined while we are prescribing, and therefore we have to be careful about the sources, how we are going to write the iron, and how we are going to ensure that it is properly absorbed and finally assimilated by the woman in context. So we cannot use like the hamburgers of the McDonald's for all women. We have to keep on looking at the various aspects which can help us in trying to reach out and then correctly be able to help. Now, this was just an overview coming quickly to the important thing that has happened on the recent past, and that is identifying this particular hepcidin. And this hepcidin is something which has an important context in pregnancy because they are known to show diurnal rhythms, and iron given in morning hours when hepcidin levels are low leads to higher absorption. And this is a new thing that we have to look at. And this is something new which we'll also have to practice because that is going to help us in better identification of the iron. And these are certain publications to which we can refer to be able to identify. And it's also found that serum hepcidin is superior to hemoglobin, serum iron, serum ferritin, transferrin saturation TIBC as an indicator of iron deficiency in pregnant women. Of course, we'll have to have more studies in the Indian context to be able to come up with this conclusion. Very importantly, pregnancy is a condition which has effects of inflammation, and this can affect the iron metabolism. And therefore, one has to be very careful whenever we are considering looking at the prescriptions of iron. Now, coming to the important part of my task today is how are you going to approach and clinically diagnose this anemia? And any diagnosis has important facets. One of the most important things is history. From all the symptomatology of pregnancy, one has to also definitely and proactively ask for pica, whether she has any dryness, giddiness, swelling, edema, is something that we ask. Very, very important is whether she is able to tolerate food, whether she has anything which is suggestive of gastrocolitis will definitely help us in identifying how am I going to prescribe and why is she having this iron deficiency. Maybe she is not able to absorb it at all, or maybe she's not having the correct dietary practices. So looking at her history in details, trying to identify whether there are any ways in which she must be losing iron. And that can be that maybe she has a worm infestation, she may be having some infection somewhere in her body, is very, very important. So beyond looking at hemoglobin, trying to establish her diagnosis is important. In the recent past, has she suffered from any viral infection? Because that can be the setting why she is already started on her pregnancy with anemia. And all these issues such as chronic fever, whether she has a history of anemia, blood transfusions, any iron therapies that were necessary, because we have become extremely complacent. Many times we say, yes, 8 gram percent, that's how my hemoglobin has been for life. It requires attention because as we saw the previous speakers talking about of everything even beyond iron deficiency anemia, and therefore this would matter. Looking at palloglossitis, cheilosis, koilonychia, Plummer-Wilson syndrome, tachycardia, pedal edema, and the hemic murmur at the mitral area is always a good practice. And this has to be done at the outset when you're doing a proper assessment of the patient at your first antenatal visit, when you have confirmed her pregnancy and have decided to embark upon continuing it. So with the purpose of diagnosis to identify the severity and the type of anemia, to assess the iron stores, and to assess the assessment of the heme iron and probability and the possibilities of any disparities in iron absorption. So hemoglobin estimation tells us about anemia, while complete blood count gives us an insight into what could be the probable cause or are there any associated abnormalities. So the anemia can be typed by looking at some indices, simple ones such as MCV, MCH, and MCHC if you have done a complete blood count. And it's always a good practice to look at the peripheral blood smear. However, many times we may not have an access to this. But even the CBC, which is many a times now mechanized, can give us a lot of answers. So this is something that should be done at the first antenatal visit. Do not get happy just by doing a hemoglobin. Definitely do a complete blood count. Now, if one has a low hemoglobin, definitely a CBC has to be done. Look for peripheral smear and RBC indices. And if you find that the MCV is less than 80 FL, then it is a microcytic hypochromic anemia. Normocytic NN would have 80 to 100, while macrocytic can be having more than 100 ml, and there can be an associated other cause of anemia other than iron deficiency anemia. Now, microcytic hypochromic anemias are usually iron deficiency, but do not be completely confident about this. The patient may also have any kind of a hemoglobinopathy. So if it is a microcytic hypochromic, consider IDA, thalassemias, anemia of chronic disease, sideroblastic anemia, copper deficiency, or lead poisoning. And this is a true, especially industrial bells can be a possibility. Normocytic normochromic may be hemorrhagic. Early iron deficiency anemia, it may definitely gradually transit into an IDA, anemia of chronic disease, bone marrow suppression, endocrine dysfunctions, usually hypothyroidism and diabetes, autoimmune hemolytic anemia, hereditary spherocytosis, hemolytic anemia associated with PNH can also be a possibility. Now, folic acid deficiency anemia, vitamin B12 deficiency, drug-induced hemolytic anemia, liver disease, ethanol abuse, acute myeloid syndrome will all be overt only if you really take a careful history. Now, once your MCV is less than 80 FL, look at the retic count. And if you find that it is normal or decreased, then this is a patient which requires iron studies in the form of ferritin levels. Look at the TIBC. Normal or low TIBC, normal or high ferritin will tell us about anemia of chronic disease. Low ferritin, high TIBC would tell us about iron deficiency. And then you get a guideline. We have to be absolutely medico-legally sound when we are considering parenteral iron in our patients, and doing a serum ferritin, establishing that she has iron deficiency helps. And that is one of the important evidences which proves that it is IDA, and it then justifies your parenteral iron therapy. If it is normal to high iron, any TIBC, normal or high ferritin, it could be thalassemia or sideroblastic anemia or sickle cell disease, for which we need to do an HPLC. But mind you, friends, HPLC should be done with at least a corrected hemoglobin level. Do not do it when the patient presents you with very severely low hemoglobin. At least a hemoglobin has to be 9 or more to perform the HPLC, is what the hematologist advocate. And I know we have a hematologist who will be speaking after me, so I will have a reiteration of most of the things that I'm already saying. So microcytic hypochronic anemia requires attention. You have to look at the smear and all the parameters to differentiate between deficiency, anemia secondary to inflammation, which is a commonality in association with preeclampsia or the puerperal anemia, post C-sections especially, thalassemia, and sideroblastic anemia. So these require to be analyzed properly and then accordingly approached rationally and scientifically. Now, serum ferritin concentration forms the most accurate diagnostic test in patients without any underlying inflammation, and that can be our easy go-to thing for obstetricians. If you find any disparity, you can always consult a hematologist to put your patient on the right path. So if you look at the algorithm from the ferritin point of view, if you find that the ferritin is more than or equal to 30 micrograms per liter, and if you're looking at the hemoglobin levels trimester-wise, looking at the context, then the mean corpuscular volume, that is, if it is less than 70 FL, consider thalassemia. If the C-reactive protein is found to be more than 1 milligram per deciliter, then it is because of an inflammatory pathology. We can always also look at the leukocytosis, and that can give us a vision in some ways, rather than sometimes we may not be able to put the patient through ferritin. If the ferritin is found to be less than 30 micrograms per liter, look at the context of what is the hemoglobin level, and then if it is found to be low, it's iron deficiency anemia, and this is something that we require to look into and accordingly approach the patient without therapy. Now, peripheral blood smear has a huge lot of place wherein we can look at the morphology of the RBCs, anisopoikilocytosis, platelets which are increased, and target cells which are usually seen in thalassemia rather than IDAs. And this is something that we must definitely reiterate and get it done from our pathologists. So if you look at the indices in iron deficiency, you will find that the RDW is more than 14, MCV is between the range of 80 to 100 or sometimes less, serum ferritin less than 15, serum iron less than 60, TIBC more than 390, transferrin saturation less than 15, zinc porphyrin or iron protoporphyrin raised, iron absorption 10 to 20, and SPFR, if you have done, it's found to be raised. So these are something that we can use to analyze the hemograms of the CBCs that come across to us. And then we have to also remember that apoferritin plus ferrous iron is equivalent to ferritin in a ferric form. And it's a marker for storage iron. And first to decrease, more sensitive marker of actually the iron deficiency. The hemoglobin will be normal, but still the serum ferritin may be low. And 1 micrograms per liter is equal to 8 milligrams of storage iron. And it's unreliable in acute chronic inflammation, delivery, liver disease, malignancy, hyperthyroidism, and heavy alcohol intake. And these things require to be looked into whenever we are making a diagnosis. So if you look at the effects of iron supplementation on serum ferritin concentration and pregnancy, there is definitely an improvisation, and that is something that we require to look into. One has to always keep thalassemia as a differential, and I think there's no excuse not to screen any patient for thalassemia. It's always a good practice because that can give us insights and then help us in trying to curb the malady of thalassemia. And then, of course, the other investigations which may be considered usually are done by the hematologists, colleagues of ours, wherein we look for free erythrocyte protoporphyrin, and then these are known to be increased in iron deficiency anemias, erythropoietic protoporphyrias, chronic anemias, and lead poisoning. So these are something that we really do not require to look into, but these are what the hematologist, but we should know when should we refer to the patient to them. And we should not just be pushing into iron to this patient indiscriminately. There has to be a rational, and these are some things that we require to look into. It's important to understand the role of additional investigations in patients who have no inflammatory states and in whom the ferritin level is indeterminate, and further tests can be performed to ascertain the storages. So patient with anemia who has an MCV of less than 95 FL, we have already discussed, we have to look into and go about diagnosing this condition. So the gold standard ideally for iron deficiency anemia is absence of a stainable iron on bone marrow biopsy. And this is something that is not routinely done, but this is something that will be considered by our friends. We as referring doctors should be aware of this, that bone marrow biopsy is usually indicated when there's failure of therapy, when there is hypoplastic, aplastic anemia, or any other disorders. And we have to also be very sensitive to understand that if you look at the stages of iron deficiency, you will find that hemoglobin usually will be presented much, much late after a huge balance of the iron storage has completely been toppled down. Till that time, the body keeps on maintaining, and usually serum ferritin therefore acts as a better marker. So we have to be looking at least the complete blood count and the peripheral smear carefully. I am sorry, there has been a Nestroff test which has been added here. And this is something I'm sure our hematologist friend and colleague will describe us much in details. What we also have to look is when we are giving iron therapy to the patient, get into the habit of looking at the retic count, because retic count is a very sensitive marker. And it also, if it is found to be increased, it can be a sign of hemolysis, and it can be reduced in various kinds of anemia. So in summary, anemia is seen frequently in pregnancy. The most common are iron deficiency anemia and the folate deficiency megaloblastic anemia. And these are very common in women who have inadequate diets and who are not taking any prenatal iron. And therefore, when we're talking of preconceptional optimization of women, iron deficiency correction has to be a main goal, especially 3 months prior to the conception if we have such an opportunity, along with the folate supplements. And I would like to also add calcium at the right time, because this can go a big way in preventing many adverse pregnancy outcomes. And it is important to have a detailed investigation of acquired anemias during pregnancy, as it is very important considering that inadequate nutrition and nutritional deficiencies have an adverse impact on pregnancy outcome. I like to end this talk with a lot of gratitude and thank you for your patience and the opportunity. And once again, congratulations to Dr. Preeti and her team for having such a wonderful anemia-focused conclave. Thank you so much.
Thank you, ma'am, for your kind words. Now I will request Dr. S.P. Jaiswal, ma'am, to invite respected Dr. A.K. Tripathi, sir, for his talk. Dr. S.P. Jaiswal, ma'am. Dr. S.P. Jaiswal, ma'am. Now I will introduce Dr. A.K. Tripathi, sir. Sir
Yeah. Now,
okay,
I am here.
Okay.
Actually,
okay,
I was
welcome,
not muted myself.
Okay, welcome,
This
ma'am.
good afternoon to all of you. After wonderful talk of Dr. Jaideep Tank and Dr. Girija, I have proud privilege. This is my great privilege to introduce Dr. A.K. Tripathi, who is a great hematologist. We worked together for many years, and he helped us a lot in managing the patient who comes with the anemia, and it's difficult to make out what is the cause of anemia. So we always refer to him for help, and he's always helped us. He is a director of RML Institute after heading the Department of Hematology in KGMU as a professor and a head. He is a founder, head of this department also, hematology. He received a national award from Department of Science and Technology of the government. He is a visiting scientist of many international and national department, national as well as he has worked as a visiting fellow also in many hospitals like in USA, Oxford Hemophilia Center, UK, and he's having many original research paper, more than 140, and he is a writer of many books also. He's a very nice fellow. He is very nice and is good colleague to us and always helpful to us. Dr. A.K. Tripathi, he is going to talk on hemoglobinopathies in pregnancy. We heard about the iron deficiency anemia. Now he is going to cover hemoglobinopathies in the pregnancy. Sometimes we have lots of confusion in that. Dr. A.K. Tripathi, please.
Yes, can I have slide, please? Hello.
A slide, please share slide of Dr. Tripathi.
And उनकी slide लगा दीजिए, please.
Yes, ma'am.
Thank you, Professor Jaiswal, for kind introduction. But there is a little correction. I have just 2 days back, I have joined back as a professor and head of clinical hematology, KGMU.
Sir, always welcome, sir.
Yeah, and
always with us. Thank you.
And respected chairpersons, Madam, good afternoon. Can I have my slides?
Welcome, Meera ji.
Can I have a line, Jaiswal, Dr. Jaiswal?
Yes, ma'am. Most welcome.
You have given a lovely introduction of Dr. Tripathi, but you have left one very important thing. He is a student.
Maybe hidden from me.
No.
Don't know about that.
He is a student of GSVM Medical College.
That's good.
He is a topper of all the years. And one important thing that he got distinction in obstetrics and gynecology. And I'm an examiner of this boy. सब लोग wonderful देख रहे थे क्या? He kept on answering. कोई answer नहीं ऐसे करेगा. Objective, forceps, everything he kept on answering. So he is just topper of this thing. So I am a proud teacher, first of all.
Definitely, sir.
मीरा तुमसे हम लोग ने छीन लिया एक-एक को बस
चंद्रा जी, देखिए मीरा जी ने बताया ना अपनी इम्पोर्टेंस, उनका
हमने
स्टूडेंट
छीन
है।
लिया उनसे।
नहीं चंद्रा
हम
जी,
लोग तो ऐसे खुले ही
चंद्रा जी,
जानते हैं।
हम लोग दोनों
Furkan, can we have the slides of
Slides, please. Slides, please.
presentation, please?
Yes, madam, we are just putting.
And respected Alpesh Gandhi ji, President FOGSI, most respected Professor Chandravati, my teacher Professor Biraj Mutri ji, I am very much humbled by your blessings, Madam, Dr. Preeti, and all participants. Can I have my slides, please?
सर अभिषेक आपकी स्लाइड शेयर कर रहे हैं सर आपके साथ.
We had very good presentation by Dr. Girja Wag. It was very comprehensive presentation on iron deficiency anemia. So this made my job very simple now. Before I start my presentation, I would like to highlight 2 points. Hypoglycemic are not patients with iron deficiency anemia. So one should not give iron to all patients who have anemia with microcytic picture. Number 1. Second is, even if patient does not have anemia, the patient may have asymptomatic hemoglobinopathy, like alpha thalassemia or beta thalassemia trait. And if that diagnosis is overlooked, patient may have hemoglobinopathy associated complications in pregnancy. So one must screen in all patients during antenatal period about the presence of hemoglobinopathy. Next slide. I would like to talk about the structure of hemoglobin, what are the different types of hemoglobinopathies, and how do we diagnose and how do we manage hemoglobinopathies in prenatal and antenatal period. Next slide, please. Hemoglobin is tetramer. It has 2 alpha chains and 2 beta chains and 4 heme molecules. Next, please. Next. And this shows that hemoglobinopathy is a genetic disorder and there is a mutation or some change in chromosome. Alpha thalassemia, you can see on chromosome 16, and beta thalassemia arises from mutations in chromosome 11. Next. I would like to draw your attention in this very important slide. The top one is the blue one. You can see the alpha chain is present throughout, while the red one, beta chain, is present only after birth. So after birth, you see the 4, on your right side, you can see the 4 lines. The blue is alpha, followed by beta, and gamma and delta. So alpha and beta is normal hemoglobin, while alpha and gamma is fetal, which is present in less than 1%. Next slide, please. Yes. Now you can see that in a healthy person, more than 96% is hemoglobin A, that is alpha 2, beta 2. While hemoglobin A2 is around 2.5%, that is alpha 2, delta 2. And fetal hemoglobin, that is alpha 2, gamma 2, is less than 1%. Next slide, please. Next. Hemoglobinopathies are autosomal recessive inherited disorders because of decreased synthesis of normal globin or synthesis of defective globin. If there is a defect in the synthesis, in the reduced synthesis, this is called beta thalassemia or alpha thalassemia. If the structure of globin is abnormal, it is called sickle cell. Next. This is depicted in this slide. Qualitative disorder means hemoglobin differs in sequence of amino acid. So its structure is different. And the examples are sickle cell anemia, methemoglobinemia, and cyanohemoglobinemia. And if structure is normal, but the amount of production is reduced, that is decreased production of globin chain, then it is called thalassemia. If there is reduction in production of alpha chain, it is called alpha thalassemia. And if there is a reduction in production of beta chain, it is called beta thalassemia. Next. So this is a detail about structural defect. It occurs due to mutations either in alpha chain or beta chain, and due to substitution, addition, or deletion. And the examples are hemoglobin S, that is sickle cell disease, hemoglobin C, hemoglobin E, D, and so on. Next. And thalassemia means there is decreased production of globin chain, but structure is normal. And it occurs because of deletion, point mutation, or insertion and deletion in the genes. And if there is a reduced production of alpha chain, it is called alpha thalassemia, and reduced production of beta chain, it is called beta globin chain, it is called beta thalassemia. Next. 5% of population are carrier for hemoglobinopathies worldwide. Annually, 3 to 4 lakhs children born with clinically significant hemoglobinopathies. And as you see, 56,000 conceptions are born with thalassemia disorders. It is more common than ever before because now we are able to diagnose more often in our patients. And next slide. Next. The major type prevalent in India is beta thalassemia, which can be beta thalassemia major or minor, and sickle cell disease. The estimated burden in India is about 42 million carriers of beta thalassemia, which is largest in the world. And it is more prevalent in certain racial groups, ethnic groups like Sindhis, Punjabis, Gujaratis, and others. Next. And you can see the worldwide distribution of hemoglobinopathies. The green is thalassemia. It covers India and then Southeast Asia, Middle Eastern countries. And if you focus attention on India, map of India, you see the half below, the lower half is denoting hemoglobin E, and the dot, pink dot, is hemoglobin S. Next. Next. And this is hemoglobinopathy burden in our country, present almost everywhere, but most prevalent in Assam, where hemoglobin E is very prominent, Odisha, hemoglobin E, as well as sickle cell disease and others. Next. Next slide, please. Next. The same thing. Next. Next. Sickle cell disease arises due to point mutation in beta chain at codon position 6. And the valine is replaced, glutamine is replaced by valine. It is autosomal recessive, and it is the most common inherited hematological disease worldwide. Next. Here in this picture, you can see there is a mutation. That is why glutamine is replaced by valine. If it was glutamine, the structure was negatively charged. But once it is replaced by valine, it becomes non-polar, leading to change in the structure of hemoglobin. Next. 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 And if there is one allele involved, it is called sickle cell trait, and this is called sickle cell disease. You see in the sickle cell trait, hemoglobin is clearly normal, while in disease, it is low. In sickle cell trait, hemoglobin, normal hemoglobin 40 to 60%, while in disease, 70 to 90% here is sickle cell, and rest is hemoglobin F. Next. Again, this is shown that if this is normal, this is abnormal. If one allele is involved, this is called sickle cell trait. If both chromosomes are involved, then it is called sickle cell disease. Next. Next here. Go ahead. Yeah. Yeah. Please go ahead. Yeah. Yeah. Because of change in the structure of amino acid, there is polymerization of hemoglobin molecule, leading to sickling of red blood cells. Next. Yeah. Next slide. Next slide. And that results into a variety of clinical manifestation. It is chronic hemolytic anemia, and these patients may present with painful crisis, painful leg syndrome, hyposplenism, and they are at increased risk of infection. Because of chronic hemolysis, these patients may have iron overload, and avascular bone necrosis, and other complications. It is associated with significant morbidity and mortality during pregnancy, associated with increased chance of miscarriage, infection, intrauterine growth retardation, preeclampsia, stillbirth, prematurity, and more importantly, thromboembolic complications, which is generally more in pregnancy, normal pregnancy, but it becomes much more if pregnancy is associated with sickle cell disease. Next. Thalassemia, as I told, it is because of reduced production of normal globin chain. If there is a reduced or absent beta chain, it is called beta thalassemia. If reduced or absent alpha chain synthesis, this is called alpha thalassemia. Next. Next, the same thing. Alpha thalassemia, there are 4 genes. If there is a single gene defect, that there is no problem. Even 2 gene defect also, patient may have mild anemia trait. But if there is a mutation in 3 genes, it is called hemoglobin H. Now this is clinically significant. And if there is a defect in all 4, these the fetus doesn't survive. Next. Next, go on. Yeah, go on. Next. Yeah. Next slide, please. This is beta thalassemia. As I told, if there is a reduced production of normal globin chain and beta chain, it is called beta thalassemia. And it is either minor, intermediate, and major. This is a clinical phenotype. Major is a severe disease, while trait is silent or is almost asymptomatic, and intermediate has moderate problem. Next. Beta thalassemia major. Initially, it may be asymptomatic because of fetal hemoglobin, but after 6 months, patient anemia becomes severe. The patient is transfusion dependent. These patients are very severely anemic, and generally they don't survive if not treated properly. Even if they treated properly, they don't attain proper puberty, and also they have fertility problem. While beta thalassemia minor, these patients are maybe asymptomatic, and these are the ones, once they grow and attain puberty, they may become pregnant later on. Next. This is a very important slide. What happens in thalassemia? Because of reduced production, there is ineffective erythropoiesis. Reduced production of RBCs leading to anemia, and because of reduced production in bone marrow, there is extramedullary hematopoiesis. Liver and spleen take part in RBC production. So there is splenomegaly, there may be hepatomegaly, and also bone marrow expansion. So this is because of ineffective erythropoiesis. There is destruction of these defective red blood cells. If there is increased destruction, patient has anemia, patient may have gallstone, and also accumulation of iron. And this is very important, and because you know free iron is very toxic. This gets deposited in various endocrine organs, parathyroid gland and pituitary gland, pancreas, testis. So this leads to pituitary gland deposition, leads to growth failure, pancreas leads to diabetes, testis, ovary leads to infertility, and deposition in liver leads to liver failure and heart failure. So these may be presentation in thalassemia. And one which is generally missed is hypercoagulable state. Pregnancy itself is a procoagulant state. The person is, a lady is more prone to develop thromboembolic complications. But if she has thalassemia, even if it is asymptomatic thalassemia trait, she is much more likely to develop thromboembolic complications. So one has to be very careful about this. Next. Next, I think you go ahead to the next slide. And these are the manifestations of thalassemia. Like patient is anemic, and because of iron overload, patient has hepatic dysfunction, endocrine dysfunction, delayed puberty, infertility, increased risk of infection, cardiac involvement. And as I highlighted, in pregnancy, presence of thalassemia increases the risk of thromboembolic complications. Next. When to suspect, if a pregnant lady is anemic, even if she is not anemic, one should investigate for the presence of hemoglobinopathy. As I told, hemoglobin may be normal, but the lady may have thalassemia trait, and she may develop some of the complications of thalassemia trait even without anemia. So one should, there is no question of suspicion, one should investigate for the presence of hemoglobinopathy during antenatal period. Next.
Dr. Tripathi, we are behind the schedule, please.
Yeah, so I am moving fast now. I think this has been very elaborate, very beautifully elaborated by Dr.
Yeah, but your talk is also very good because we are not so much aware of it. But
so
there
next
is
slide. Next slide. Yeah, this is also very well described by Dr. Wag, but just to highlight one point, it is amount of hemoglobin A2. And if amount of hemoglobin A2 is more than 3.5% and RBC count is more, MCV is low. This is indicative of thalassemia. And hemoglobin A2 less than 3.5, this is normal. Even if hemoglobin A2 is less than 3.5, but if RBC count is more microcytic, one should also suspect thalassemia. Next. Yeah, go to next slide, please. Next slide. And diagnosis is the preferred mode of investigation is HPLC, although you can order for electrophoresis as well. And this is for molecular analysis. Next. Yes. So next, yeah. So this is electrophoretic pattern. This is normal. And this is beta thalassemia trait. You can see increased hemoglobin A2. This is beta thalassemia major. You can see increased level of fetal hemoglobin, hemoglobin F. In sickle cell, you can have additional band of sickle hemoglobin. Next. This is some details about molecular-based analysis. Next.
And a section bearing usable code, such as a BNTR or STR, is isolated.
Next. Yeah, so this is diagnosis of sickle cell disease. The patient has hemolytic anemia, low hemoglobin, high reticulocyte count. Peripheral blood smear examination shows sickle cell, and is confirmed by HPLC or gel electrophoresis. Next. Yeah, this is peripheral blood smear. Next. Yeah, next. Yeah, go ahead. Yeah. And finally, hemoglobinopathy status allows increase. What is the advantage of prenatal testing? Because and based on the finding, the patient may have reproductive choices. And antenatal screening is to identify who carries significant trait, and if the spouse is also carrier, then there is 25% chance of having thalassemia major in the baby. Next. And you can see in almost all types of hemoglobinopathy, there is increased maternal risk. So the bottom line is that please always screen for the presence of hemoglobinopathy in a pregnant lady. Next. And this is, I have already told, but this is a summary of what should be done for the screening for hemoglobinopathies. Next. Yeah, go ahead. I think I already discussed here. And this is screening of a spouse. One should also screen a spouse in order to predict the chance of having thalassemia major in the baby, so that the parents may have reproductive choices. Next. And finally, management, just few lines. In sickle cell disease, if patient is on hydroxyurea, that should have been stopped at least 3 to 6 months before conception. And the drugs which are teratogenic must also be stopped. And these patients should be given folic acid regularly. Next. Now, thalassemia. After genetic counseling, blood grouping, viral screen for hepatitis B, hepatitis C, HIV, and ferritin monitoring is necessary because these patients generally have high iron load. So if patient has high ferritin level, it should be decreased by chelating agents before the lady plans for the pregnancy, because chelating agents are contraindicated during first trimester, and if very much needed, desferrioxamine can be given later on in the second and third trimester. Next. Vitamin C must be stopped. Iron is contraindicated unless there is iron deficiency. And you already know folic acid, vitamin D, these are all given. Next. So to summarize, hemoglobinopathies are divided into disorders like decreased production or structurally defective production. Thalassemias are considered most important. High index of suspicion is needed. And prenatal diagnosis is most important aspect of management. I think this is the last slide. Next. Thank you very much. Thank you.
And unmute yourself, please.
Thank you so much, Dr. Tripathi. You made the subject so simple because we obstetrician, we don't know so much about this, but definitely, as we know beforehand, at least we can counsel the patient which patient can continue this pregnancy and which cannot. Thank you so much. Meera?
I request Dr. Atul Garatra, sir, is he here? Sir, could you give your concluding remark for Dr. Jaideep Tank's talk, and Dr. Nija Matla ma'am requested to give a concluding remark for Dr. Girija Wag's talk, ma'am.
Okay, thank you.
Dr. Atul Garatra, sir, is not there, I believe. Dr. Nija is there? Madam, are you there? Okay. So I think our chairpersons have
Hello.
probably.
Dr.
Ma'am,
Nija is
we
here.
need a concluding
Dr.
remark
Nija
for
is
you.
You know, the talks were really illuminating, and I thought there were many new things to learn and take home the practice points. I remember years ago, there was this person from WHO who would say that if the women cannot have access to blood banks, build a blood bank in their bodies. So I think that is our goal, that we have to make sure that the woman starts with a reserve where she can afford to lose a little bit of blood and not be in dire straits because she's just on the margin, leave alone the impacts for her baby. So I think it's been very interesting to see how much the progress has been made in the understanding and how we have to look for new strategies, because this is not working very well clearly if we have not been able to dent it. So there's a lot of scope for improvement on strategy, on implementation. And the COVID has been a bad time, and people are coming now with such severe problems, including anemia, including we recently had an eclampsia in a well-to-do family. So we have to tailor our prescriptions to the times and make it sure that everyone gets what they need. So thank you for this opportunity today.
Definitely, Dr. Neja. This is your experience. We are also facing the same thing, the severe anemia, eclampsia. They are increased in such a huge amount in our hospital. Maybe because of COVID, they have not got proper treatment. And this anemia is a condition which can be eradicated completely by little knowledge, emphasis, and maybe as Dr. our FOGSI president says, if we all work together, definitely we will win on that. Thank you so much. Thank you, Preeti.
Thank you, ma'am. Thank you, ma'am. We move on to the next part of the conclave. And it's truly a galaxy of FOGSI stars, you know. We not only have the current president, the past president, but also the future president with us today. Dr. Shanta Kumari, madam, sends her good wishes, and she had to honor her prior commitment, so she's not with us today. But no problem. We have President-elect 22-23, Dr. Rishikesh Pai sir with us. So welcome on this conclave. And to introduce you, I fall short, sir. Very much short. it's a massive, inspiring CV here. All I can say is that you've already had all the positions. You are presently Medical Director, Bloom IVF, past Secretary General, Senior Vice President, Deputy Secretary General, you name it, and every post that you've held. So welcome. I will not use the word waste, but I will not, use the valuable time here to deliberate on your CV. And I request you to put your thoughts forward for FOGSI's future vision, sir. Welcome, sir. Sir, you have to unmute yourself, please, sir. Sir, you're not audible. Sir, unmute, please. Thank you, sir. No. Not yet, sir. Abhishek, Dr. Connectivity lose what? Ji?
Dr. Meera, I think he must be having some system issues. So I
Okay.
think he is joining back after disconnecting.
Okay.
It's a system issue that
Yes, sir. Sir, we can hear you. Welcome back, sir.
Okay,
Welcome back,
you.
sir.
So I would like to acknowledge Dr. Alpesh Gandhi and our Vice President, Dr. Atul Ganatra, who is no longer there, Dr. Chandravati and Dr. Meera Agnihotri, our leaders, and I would now add Dr. Hema Divakar also, who is there with us. And of course, Preeti, who has arranged this program. And, I can see a lot of people here, Dr. Jaiswal, Dr. Nirja Vatla, who is very dynamic, Dr. Meera Lakatia, Dr. Girjawang and Jaideep Tang had just come and given us, and Lakshmi Shikande and Anaita Chauhan from our journal is also there. She's the secretary of the MOGS, and I can see Mr. Chirag Amin as well. So anyway, I just wanted to just share my thoughts with you guys about anemia. So thanks Preeti, because it's it's high time I started thinking what I'm going to do in 22. And COVID, of course, there's a lot of downside, but it's given me a lot of time to think what is the thing we can do, how we can change the track of the federation, how we can create an impact on the lives of Indian women. So I was looking, and if you look at anemia in India, the anemia is very prevalent, and the lifetime cost of iron deficiency anemia between the ages of 6 and 59 months amounted to 8.3 million disability adjusted life years. It is called DALIs, and the annual production losses of 24 billion in 2013, which is nearly 1.3% of our GDP. And again, it also contributes to nearly 20% of maternal deaths. So why is there anemia in India? I asked myself a question, what is the reason? Why is there anemia in India? One is because we are a poor country. There's a lot of poverty in our country. And if you look at the Asian Development Bank estimate, India's population presently is 1.28 billion with an average growth rate of 1.3%. 49.9% of this population is below the age of 15 years, and 6.9% of the population still live below the national poverty line. That is defined between $1.25 to $2 a day. And that is the national poverty line, which has been defined by various, even the Millennium Developmental Goals has shown that $1.25 has been taken. So one is poverty. Because of poverty, we don't have access to food. You don't see much of any. And the second problem in India is a worm infestation. So I was looking at the net, and there was this paper where they randomly studied school children, and they found 36% of them. They did a stool examination of nearly 250 girls, and they found in 36% there was infestation with Entamoeba histolytica, Giardia intestinalis, Ascaris lombardis, and hookworm. And the prevalence of anemia in these patients who were infested was nearly 84.8%. So worm infestation, and of course, because there is no food, we are very poor. We don't have even 2 meals a day. This, along with, despite of that, when the government of India, they implemented the program, and that is called the National Iron Plus Initiative Guideline. And this was developed by Adolescent Division of the Ministry of Health. 2007, 2011. So despite of that program, how come we are still having a problem? Because there are problems in implementation. So we have defined a problem. We know what is the problem. So how do we implement it? How can FOGSI help in the implementation of this program? So we have to look at implementation because a woman ultimately, she is born, then she becomes an adolescent, then she comes in the reproductive age group. So we have to counter anemia at all these levels. And so the national program has countered it by saying that they get supplemented during the school hours. The ASHA worker supplements them. But one of the things we'll have to do, suppose we have a population of say 1 million in a town. How do you diagnose who is anemic? Are we going to do a prick on everyone? So point of care diagnosis is very important. And when Rishma was the president of FOGSI in 2017, Hema Devakar and me were very much obsessed with the point of care. We nearly developed the Nari Swasthya Program, which was an excellent program. We wanted to do a point of care. So there are different ways in. So if you have 100 women, we need to know how many are anemic and how many are potential anemic. So we need to actually divide the two. So by doing a prick method, but prick method is invasive. Now in COVID times, it is going to be more invasive. So a non-prick invasive method using spectrum photometry, or you can also use like oximetry type of devices there, which is quite good. They are not as accurate as the proper method of having a venous blood collection, but that can actually differentiate anemic people from non-anemic. So the non-anemic, the government has already got program for supplementing them in the schools, in the community by using the PMSMA program. I was fortunate enough when I was Secretary General of FOGSI, we launched the PMSMA program along with the IMA, and that time Arka Kripalani was the president of the FOGSI. We launched it with the PMO, and so we can use a PMSMA program. So once you diagnose the program, then you have to supplement and integrate. So now here also again there is a problem, because when you can just supplement iron, what about vitamin D? What about carbohydrates? What about fiber? What about iodized salt? What about folic acid? So we need to have an integrated supplementation program. We can't just say, I'm chairman of this committee, so I will only do iron. We need to give them the nutrition. We need to give them the protein so they don't get malnourished. So we need to integrate so I am all the time saying that integrate, consolidate. Don't bifurcate. In the same, if Dr. Nirja Badla is there, integrate the program. Along with that, also screen for breast cancer, also screen for cervical cancer. Also ask whether your first relatives have got cancer, so you can screen them aggressively. Also ask them for sexual health. Are they having an assault in the family? Are they having sexual exploitation? When you have that woman coming to you in the PMSMA program or in your private clinic, you need to attack her on all aspects of it. Integration. Maybe we cannot do it as human being, so we can use artificial intelligence and robotics. In the future, if a woman comes to your clinic, you may use robotics and artificial intelligence. So she goes through the questions. Maybe a robot asks her the question, because a human being can't do that. And the robot picks up, oh, there is a first cousin who has got intellectual impairment. Let us also do genetic testing in a prenatal. So if you can integrate all that, if you can connect all the dots at that point in time, that is what is important. And that was actually the concept of implementing the Nari Swasthya Pahel, which I will, when I come back. So that was a time when I could not do it adequately. This time when I come, I will aggressively do it. I'll at least cover 25 crores of people in this country through this program and through the federation. So that is as far as the pregnant women. What about the non-pregnant women? So you are all the time focusing on pregnant women. The non-pregnant women have to be through the wellness clinics of the government, the wellness program of the government, where NCDs have to be screened. That has to be the basic plan which has to be utilized by all NGOs, including FOGSI, to target the non-pregnant women. Again, in an integrated fashion, cancer, mental health, sexual health, contraceptive health, and curative services of gynecology all have to be put together. Now, what is the problem which we are going to face in the future? This is and one comment on thalassemia and sickle. So prevention. So we have a Madhya Pradesh, massive amount of sickle cell anemia is there. In fact, I know because I work in molecular biology as well, and I know that the PMO has got a huge amount. Mr. Modi is obsessed with taking care of sickle cell anemia in this country, and there is an institute called IGIB in the New Delhi where massive amount of funding is going on for treating sickle cell. Already those that are born, but we need to prevent sickle cell. So pre-conception, every gynecologist should have should do hemoglobin electrophoresis to pick up that thalassemia minor patient so that he can tell them and pick them up in the prenatal period. And of course, also offer services like pre-implantation genetic testing and prenatal diagnosis. So ultimately, the last two words is that now in all this, we were doing very well. And we were progressing very well, and suddenly COVID came in. So we are going to face a resource crunch. Our health program is set back by 5 to 10 years because now the money has got totally sidelined. So we will have to also do sacrifice. So we have had a golden time. I feel looking back last 30 years, I have had fantastic time. The government educated me. I had to not pay a single money when I came out of KM hospital. I'm totally obligated to this country. Whatever I am today, whatever I exist, my house, my car, my everything of my life, my children's education, all is because of the government. Because had the government not given me my free education, I would have been a nobody today. So now is the time for us to pay back to the government. And that is the concept of Ramadan. We need to sacrifice ourselves. We'll have to, next 5 years are years of sacrifice. We will have to pay back to the government in terms of our time, in terms of our work, in terms of our money, all that. I call it individual CSR. Forget corporate social responsibility. I call it ISR, individual social responsibility. So this is the last thing I would like to say though. So we have a huge amount of challenge in front of us for the future. And I hope that we all as a family, FOGSI family is very strong, 38,000 FOGSI families there. And we will help the government, will help a country to progress in the future. And we'll take, whatever setback has happened in the health department, health of the country, the developmental goals. Let us hope that we can cover up the setback very rapidly in the next 2-3 years. I thank you all for calling me for this function. Thank you.
Thank you so much, sir. Thank you so much, Dr. Pai, sir. It was a great honor for us. Thank you so much.
Thank you, sir. Now, good evening to all the dignitaries who are here for this very prestigious Grand Anemia Conclave. Now we preach for anemia-free pregnancy, iron for moms, and taking iron seriously. And this conclave is dedicated to the cause. So let us talk, test, and treat anemia. We start the second session of this conclave, that is the panel discussion. And this will give a deep insight on the diagnostic dilemmas in pregnancy or in anemia. Moderating this session are the stalwarts in the field of gynecology, Dr. Hema Divakar Madam and Dr. Sampath Kumari Madam, with expert views from Dr. Meera Agnihotri Madam. We have the proud privilege to introduce Dr. Hema Divakar, who is the consultant Divakar Specialty Hospital, Bangalore, and has been the president FOGSI 2013. And she is the FIGO representative for FOGSI 2016 to 2018. She is the CEO and the chairperson of ARTIST, and she is also the vice chair FIGO NCT committee. She is the national coordinator FIGO FOGSI PPIOCD program, and she has been awarded by the FIGO Woman Achiever Award and the Healthcare Excellence Award. It is an honor to introduce Professor Dr. Sampath Kumari Madam, who is the Chief and HOD, Muthi Kumaran Medical College and Research Institute, Chennai. She is the Vice President of FOGSI Elect 2022, and she has been the Chairperson FOGSI Adolescent Committee 2016 to 2018, and she has been the ICOG Governing Council member from 2015 to 2020. We welcome you, Madam. Dr. Meera Agnihotri has been the professor and head of Department of OBGYN, GSVM Medical College, Kanpur. Presently, she is the chairman of Ethics and Research Committee, State Medical Colleges of Uttar Pradesh, and she is also the president of WWW Foundation. She has been the organizing chairperson 39 AICOG Kanpur, and she is the chairperson FOGSI AIDS Committee. She is the ICOG Governing Council executive member, and she is the president of FOGSI for the state of Uttar Pradesh for 5 years, and she's also on the editorial panel of Jogi. So we welcome you, ma'am, as expert. The panelists who are on board today are Dr. Sarita Bhalirao, madam, who is the senior consultant in OBGYN, Breach Candy, Reliance, Sefi, and Wadia Hospitals, and she is the vice president, MOGS 2020 to 2021. Dr. Arun Barua, who is the senior consultant, Sampriti Hospital, Shiv Sagar, Assam, and he is the president of Dibrugarh OBGYN Society. Dr. Anahita Chauhan, who's the honorary consultant at Safi and St. Elizabeth Hospital, and she's a former professor and unit head at St. GS Medical College, Mumbai. She is presently the secretary of Mumbai Obs and Gynae Society. Dr. Vatsala Dadwal, who is the professor and chief division of maternal and fetal medicine, Department of OBGYN, AIMS, New Delhi. Dr. Chirag Amin, who is the consultant in high-risk pregnancy unit of Sterling Hospital, and he has 26 years of experience at Amin Hospital of Women. Dr. Shikha Singh, who is a professor in the Department of OBGYN, SN Medical College, Agra, and she is also secretary of Agra OBGYN Society. So a very warm welcome to each and everyone. And now I request the respected moderators to take over and start the interactive panel discussion. Dr. Hema Divakar, madam. And Dr.
Thank you, Sangeeta. Namaskar. And on behalf of Dr. Sampath Kumari and our expert on the panel, Dr. Meera Agnihotri, I must place on records that this is called a Grand Anemia Conclave, and none other than Dr. Pai, who always has the mega ideas, as I call it. He has placed it in front of all of us at the start of this deliberation, which inspires us to do more, because you've witnessed Dr. Pai's vision for not wanting to give up. Anemia has stayed with us way too long, but still we are determined to have a handle on it. In the same breath, I must say that for decades of their practice, from generation to generation, senior members like Dr. Chandravati ji, Dr. Meera ji, and others present here would have seen this menace percolating through the years. Still, they are back with us here with a hope that we can and we will and we must. So, welcoming on board our panelists, Arunda and Anaita, Sarita and Shikha, Vatsala and Chirag. Just permit me to share my slides. The tone, as I have told my panelists, will be very, very simple, because we have stayed with this problem way too long, and we want to just set the tone in clinical practice, how effectively, how well we will be able to tackle this on the ground, given all the challenges that we may have in practice, to try and do whatever best we can. Has the slide share rights been given to me, please?
Yes, ma'am.
Okay, just give me a minute.
As Madam starts her panel slide share, I just want to inform that we have almost 1,136 people logged in. So Hema ma'am, thank you so much. Sampath ma'am, thank you. Panelists, you have a big responsibility on your shoulders right now. 1,136 people are ready to listen to you.
Very good. Excellent.
So, and I'm so thankful to Sampath ma'am, despite such difficulties from Chennai, the tornado, the cyclones, she's still logged in. Thank you so much, ma'am, for being here.
Thank you. Yeah, so it just goes to prove that where there is a will, there is a way. And swimming through the cyclone, we have Sampath as our co-moderator, and Meera ji, of course, your presence and participation are always welcome. So to all the audience and my co-panelists, today's celebration is entirely on diagnostic dilemmas. So the panelists will focus on back in their clinical chambers, when they see a patient with anemia, do they really have a great diagnostic dilemma every single day with things like micro and macro and sickle and thalassemia and more? That is what we are going to discuss with the panelists, whom I have already very warmly welcomed. And we present to you the first case before Sampath Kumari takes on. Very, very common clinical scenario. 24 weeks of pregnancy. This is her second pregnancy. She has not perhaps used any contraceptive because quick succession of pregnancy. That's also another great setback for our women. 2 to 3 years spacing should be there, but her last pregnancy was just 1 year back. And she's conceived again. She's already halfway through the pregnancy, and she's come to the antenatal clinic for the first time, making an excuse this time that, oh, because of the lockdown, I could not come. And obviously, she's not taken any iron folic acid tablets, and routine hemoglobin checkup is revealing a 9-gram hemoglobin. So my questions about the dilemmas. Okay, first question to Anaita and Arunda. Anaita in a metro city, Arunda in the far northeast. Anaita first, how would you look? This is anyways very common. There's no dilemma in your mind. It must be iron deficiency. Give her something, she will improve. No dilemma, no more tests, or huge dilemmas. No, I want to do this, that, and the other. Maybe she's one rare case of hemoglobinopathy. Maybe there is another hidden cause for anemia. What would be your thought process, Anaita?
Thank you, Hema, for that question. And as you said, this is the most common scenario. She's in her 24th week. She hasn't had any iron or any supplementation in the weeks prior, and she's had a last pregnancy very close to this one. So my first thought would be that rather than just doing the hemoglobin estimation, I may want to do a CBC and a peripheral smear, because that will make me a bit wiser. But first off, I would give her iron along with folic acid and nutritional advice. So I may not even wait for the reports and go on a presumptive diagnosis of iron deficiency, as that is the commonest, or I would say a nutritional anemia rather than anything else.
Great. Thanks, Anaita. Arunda, in northeastern part where you are always, troubling our minds with, you have to do further investigations because some hemoglobinopathies are common there. So tell me, how would you look at this? 9 grams, second gravida, mid-pregnancy, first visit.
9 grams in my part of the country is not really anemic in a common sense, because it's almost, we hardly see people, women who have more than 10 grams in the society now. Because thalassemia is so prevalent, so rampant. We have a lot of worm infestations going around, and the nutritional component is far below the national level. So anemia per se is pretty common. To say and cover up all, I'll always agree that yes, iron deficiency will come at the priority, and we'll always remember this, keeping her history into our mind. But at the same time, we must look into the family, whether the whole of the family members are anemic. In that scenario, some sort of thalassemia could also be thinking process will really come.
Just a small question, Arunda. This lady has come now, then you're calling her whole khandan to your clinic?
No, not a question of khandan, but we'll take a history of from the patient herself, whether her family members, the anemia is rampant or anemia is so common, or it is simply her or she who is presenting with this sort of hemoglobin in this scenario. So
Anita wants to respond. Anita.
Because her previous pregnancy was a year ago, and I assume that that was an attended birth, we have more or less ruled out a thalassemia. It is my take on the case.
Okay, good. Now we come to the other duo, Sarita and Shikha. Shikhaji, you're a professor in the medical college. So as a professor, would you like to roll out a whole chain of investigations?
Ma'am, first of all, we would like to go to less number of investigations, which would include CBC and a peripheral smear.
Yeah.
And if the CBC and the peripheral smear are is suggestive of iron deficiency anemia, which is the main suspicion of our case in this presentation, then we will not step to other investigations. But if there is doubt,
शिखा जी, इसका कोई भरोसा नहीं है. शिखा जी, इसका कोई भरोसा नहीं है. फिर से आएगी भी या नहीं. First time she is come. अरे लॉकडाउन का भी बहाना कर रही है. Why don't you give her parental iron and send her off? थोड़ा तो सेफ्टी रहेगा ना आपके लिए.
If the patient is of the type that we are feeling that maybe the return visit is not ensured, then parenteral iron at this visit can be easily given, and it could be a shot of 500 milligram that can be given, right, thinking because the diagnosis is mainly in favor of iron deficiency anemia. So, and the return visit is not sure, then giving parenteral is a very good option in cases in which we don't rely that the patient will be regular in taking the iron oral and also getting investigated and also coming for review. So parenteral, especially in this COVID era, in which return visits are not ensured, so parenteral can be easily given, and no admission is required, and patient can be given, and after the infusion she can be sent home that very day.
Great. Let me swing to Sarita Bhalerao. Sarita ji, do you want to give her parental iron, like how
no. See, in my practice, I wouldn't go for parenteral iron right in the beginning. One thing is it's expensive. Second thing is that it has to be given in some hospital setting, even if it is in a casualty or in an emergency ward. So I think the patient who has come with 9 gram hemoglobin at 24 weeks, we have adequate time. And I would like to give her oral iron and dietary advice and wait for 4 weeks and see. And this hemoglobin electrophoresis, we are doing a screening for all patients. So I think that that is something one can definitely do.
Okay, so a metro city like Mumbai, Dr. Sarita Bhalerao opines that yes, hemoglobin electrophoresis worthwhile doing. That is what has Dr. Tripathi said also, and there were a few other guests on the talks today who said if we extensively do the hemoglobin electrophoresis, maybe in the long term for the entire population it may benefit, because though we talk about geographic pockets, just look at the number of migrants from one area to another. Everything is getting so mixed up, so you don't know who is where. So Sarita has waited for 4 weeks, and lo and behold, the patient is back with 8.8 grams hemoglobin. This set of questions now go to Vatsla and Chiragji. Vatsla first. So now few investigations, few of our panel members have said CBC and peripheral smear, which most people will say, okay, if you can do it, no, not a big deal. Okay. Sarita has said hemoglobin electrophoresis also. But I want to ask both of you, Vatsla first, what is the place of the serum ferritin, serum iron, TIBC, serum transferrin? अरे पूरे iron profile कर दो, पूरे जानकारी लेके इनको आगे कदम बढ़ो और treatment करो. What is your take, Vatsla?
So you're talking once she's come back for a follow-up after 4 weeks?
Yeah, she's 8.8. She's
so
stuck at
she has
8.8.
not responded to oral iron. So it could be either she's not compliant or she has some problem with absorption, or it could be that we have not diagnosed something else, like it could be a thalassemia minor. So that's why maybe she's not responded well to oral iron. So we would like to sort of differentiate whether it's really iron deficiency anemia or it is one of the thalassemias. That is the two common things, or it could be anemia of some chronic inflammation. So history again here would be important. And then yes, we could start with doing at least a serum ferritin levels. If they are low, then it's less than 30, less than 20. So pretty definite it may be iron deficiency, but borderline levels again, or if they're on the higher side, it could be chronic inflammation. We cannot differentiate.
Vatslaji, can I ask you one thing? Sorry to interrupt. See, you said that oral iron, she may not be compliant, this, that, and the other, but Shika has already opted to give parental iron. Was that not a good option?
So I would prefer to rule out thalassemia before giving parenteral iron for a patient. I wouldn't directly give, especially like in a tertiary hospital or in a place where the facility is available. Do a HPLC first.
Great. So everybody is, zeroing down to somewhere in their mind, it's better to expand our basket of investigations to include hemoglobin electrophoresis. That's what indeed we are trying to bring into the FOGSI guidelines as well. But as Dr. Pai said, if it's available in every nook and corner and it is feasible to do it, I think that should be, something that Preeti and the Safe Motherhood Committee should work towards. Chiragji, what would you say about this basket of investigations? Are they necessary, unnecessary? Serum iron, TIBC, transferrin, RDW, ये सब जानकारी से what are we going to gain?
Madam, basically, one thing I would like to stress is that in our busy OPDs, we don't give adequate time for history taking. Now, that is a big problem because many of time we miss that a patient is having some bleeding from gums or from piles or something. And if she is not responding with iron, whether she's taking with a proper instruction or not, she's taking with food, without food, with tea or without tea or what.
Sure.
So that is one issue, which is a major issue. If she is compliant and still her hemoglobin is low, she has come after 1 month. So she has come at 28 weeks. Now we have lesser of time to correct it.
Yes.
So we should not miss that part. And so I would definitely go for further investigation. Ferritin is a very good investigation for identifying iron deficiency. I would say that TIBC is not very reliable as far as pregnancy part is concerned. So the main investigation I would go for, obviously HB electrophoresis has to be there in actually first visit. But later on, if she is not responding, proper CBC and serum ferritin would give you proper picture. And then I would say 28 week plus, IV iron has to be given. We are not looking at 40 weeks. She might deliver little earlier also, and that would be very dangerous for her. So I want her hemoglobin to rise quickly. Now, once she enters the third phase, third trimester of pregnancy, the baby starts pulling lot of iron stores now. And third trimester is the main trimester where iron pulling is done.
Yes.
And because of that, she will still go down quickly. And that is why correction is important.
I think very, very, very practical points brought forth by Dr. Chirag, because it is very, very essential in the new process of thinking that by mid-trimester, you must ensure adequacy of iron supply to the baby. The reason being, even in the Anemia Mukta Bharat 2018 guidelines, they've said that you give parenteral iron as a last resort in third trimester if she's having severe anemia, because all the time we are thinking of saving the lives of the mothers. But this doesn't help the neural growth of the baby. So by 28 weeks, if adequate iron supply doesn't go from mother to the baby, then long-term irreversible complications to the baby's IQ and the other neural issues will develop, which we cannot look back. So maybe in the next amendment, we are bringing forth some data to change it. Now, let me bring in the expert, Dr. Meera ji. Meera Agnihotri ji, now you've heard all our panelists, where Anita has said it's a matter of common sense that you start with something and then you at the most add on CBC peripheral smear. Arunda said you have to look into what's really happening to that geography and the entire family, and Sarita said it's good to do a hemoglobin electrophoresis. Shika says given the opportunity, give the parental. Vatsala also says hemoglobin electrophoresis. Without that, we will not rush into parental because we may be missing hemoglobin. And Chirag brought out some very, very practical points. So with this much recap that we have had from our brilliant panelists, what would Dr. Meera ji say? I know you're going in your van, gully every day into Health on Wheels initiative from the WW Foundation, which you have established in Kanpur. What do the team in your van do? What do they do to those ladies in the slums? What tests do they do? And how you're planning to tackle anemia there? Is Meera Agnihotri there? Meera ji, unmute kijiye, Meera ji, please.
Can you hear me now?
Yes.
I agree with most of the panelists here. When the patient has come at 24 weeks, you have got ample time, and I'll be switching on to the oral therapy. I will straight away not start parenteral therapy. Yes, electrophoresis, serum ferritin. Electrophoresis will be done in the first go if the facilities are existing. Further investigations, if she has not responded to the oral therapy, Definitely, I will like to expand the basket of the investigation to come to a conclusion. And here I will be starting the parental therapy. Because in the third trimester, we don't have to take any risk. And as Dr. Chirag has very correctly told, we have to look after the mother as well as the fetus. And we have to keep the reserve for the third phase. That is, she may have PPH and other things. So we have to build up stores for that also. Under these circumstances, I will definitely go for the parental therapy because I have to build up the store for the baby and the mother.
Thank you, Meeraji. Now over to Sampath, because Sampath, see, none of the panelists are having a great dilemma. They know this is most likely to be iron deficiency. Thoda idhar, thoda udhar, nutritional supplements, deworming, oral iron, parental iron, little bit. They will extend the investigations and do the electrophoresis also, zero down on something and manage. So over to you as to what they would be looking for in the peripheral smear, etc., and how they will take the case forward.
Yes, madam. I want first to ask Dr. Arun Barua, doctor, sir, are you doing the electrophoresis for all patients at the first visit or whatever visit?
The electrophoresis in my class of patients cannot be made routine because of the financial constraint. Though the government guidelines also do not recommend it directly because the NSM guidelines are strictly followed in our region and where we do not see this particular test being done routinely. But yes, wherever we find refractory states, we recommend them, we motivate them to get it done because the prevalence rate of hemoglobinopathy in my region is very, very high. It is around 25%.
Yes, sir. Not only in your region, everywhere the electrophoresis, even in the teaching hospital, I think I saw the message from Dr. Sarita. They have sending the patients to the outside lab. So it is not, as far as I am concerned, this electrophoresis is not to be done. The main, the RBC indices itself, we can have the idea whether she is an iron deficiency anemia or what you mentioned as hemoglobinopathy. So this is the way in our hospital, I am working in a premier institute only. In that case also, most of us, we do the normal peripheral smear and come to the conclusion whether microcytic or macro. Then we can go with the RBC indices and then we can decide whether it is a thalassemia group or iron deficiency anemia. So as per all panelists, it is fantastic. Whatever the facility they have, we can diagnose in the low resource setting. It is not possible to do and electrophoresis. And as per Dr. Pai was asking, are we doing electrophoresis for all patients? Definitely not. If there is any doubt only, electrophoresis has to be done. And again, the deworming tablet, I think all the panelists will accept at the month of 20 to 24, 24 weeks, all of us are giving the deworming tablet for all patients. Mostly the anemia is with the nutritional. So the deworming should be given, and as per the scenario, you go with oral or parenteral, and if needed, only serum ferritin.
So, Sampath, this is, today's grand conclave is about diagnostic dilemmas. So let me go back to Anita and ask her. She said she'll do the CBC and the peripheral smear. What do normally the clinicians look into? It's a long report which comes and we just glance through here and there. What is it specifically we have to look at, and what is the conclusion we have to draw for the next level of action? Anita. Anita, we can't hear you.
I'm unmuting. Thank you. Just to add that when Dr. Barua and Sarita said different opinions, we will do hemoglobin electrophoresis and we don't have the facilities. I think Dr. Girija Wagh beautifully had a slide which showed the NESTROF. That is the naked eye single test osmotic fragility, which can be used as a screening test. So maybe that can be done in low resource settings to pick up the thalassemias. That's one point I wanted to make. And coming to what we would look at, suppose we did do a full CBC and the indices, I think it's important to look at the total RBC count and also the indices like MCV, because you can use a simple Menser's index and calculate whether she is likely to be thalassemia or not. in which case you can then go for the more sophisticated test of HB electrophoresis. And I think in this stepwise manner, it makes more sense, especially when resources are an issue.
Yeah, so Anita mentioned this Menser's index. Can Vatsala, can you throw more light on, as clinicians, very quickly, many have not been sensitized to look at the various parameters in the CBC. So what combination reflects on what?
So like whether it's iron deficiency or thalassemia, both may have microcytic and hypochromic anemia. But in iron deficiency anemia, the total red blood counts are decreased, whereas in thalassemia, they may be normal. And again, the MCHC maybe is reduced in iron deficiency and may be normal in thalassemia. And we talk about REW, which is increased in iron deficiency, but may be normal in thalassemia. And if you look at the peripheral smear in thalassemia, you may see target cells. So if there are more target cells, it's more like thalassemia. And not only for this, you should also look at the WBC count, the platelet counts. If both are low, maybe pointing towards a megaloblastic anemia or some kind of a bone marrow suppression or bone marrow hyperplasia. And so we need to look at the whole thing in toto.
Right. So thank you so much. Shikhaji, I want to ask you that if you've ruled out iron deficiency and if you don't have the facilities to do electrophoresis, are there certain indications where you will not bother about the cost constraints because you have to do it in cases such as for, the chronic hemolytic anemias or drug-induced or prenatal diagnosis? What are those family history or from the geographic location? What are those where you will not bother about the cost constraints, but you say, no, this patient has to have electrophoresis?
If there are some high-risk factors in the history of the patient, like if she has a previous child who has been affected by a hemoglobinopathy, if she has this history, we have to straightway go for electrophoresis. Or if she has a known family member who has this trait of hemoglobinopathy, then also we have to straightway go for the electrophoresis. Or if the red cell indices, they show that iron deficiency has been clearly ruled out. So in that cases also we will go for the electrophoresis. Or if there are history points of vascular crisis in the patient, bony pains, if she has a history of fracture, bony pain, vascular crisis. So all these, and if she is a member in which screening has to be done as a family member, already there is an affected family member and she is in the screening category for those. So in all these, we will straightway go for electrophoresis because they will be the alarming points in which we already have indication from the investigations and history. So that case, these patients will be taken for electrophoresis.
Right. So this is a subset where you cannot, when you have a thought process that no, we cannot afford it or facility not available for everybody, we will not do. But for these subset, you have to do. So having said that, let me go back to Sarita Valera. Now there is a situation where the prenatal diagnosis, she is a carrier. Okay, she is a Thal minor. And what will be your further diagnostic dilemmas or investigations that you will institute now in the husband and when early in the pregnancy for herself pointing towards the prenatal diagnosis of the carrier or the affected status of the baby, etc.? How do you look at these cases?
So the first thing we'll do is, of course, check the husband. If the husband is not a carrier, husband has normal hemoglobin electrophoresis, there's nothing to worry because the baby will be either normal like the father or will be like the mother, which is a carrier. The second thing is that if both are carriers, then in that case, prenatal diagnosis is required and we can either do a chorion-villus sampling at 10 to 12 weeks, or we can do an amniocentesis after 16 to 18 weeks.
Right. So let me swing to Arunda again.
Yeah.
Yes, Sarita.
The important thing is to find out the mutation. No, I said if we can find out the mutation, then it is better. Otherwise, we have to check for the common mutations.
Right. So, Arunda, on one hand, you are saying that yes, and it's endemic, and we'll see the family, and they may have a high chance that they thal carriers, etc. So, what is the level of facility available in your part of the country to move further, as how Sarita has given the inputs?
Yes, we understand the importance of taking this investigation forward, but we do not have the infrastructural facilities even at the best places in the region as well. So either we have to send the patient to some centers where they will collect the sample and send the sample to either Delhi, Calcutta or Mumbai, or there was a regional center being set up in one of the medical colleges which could not sustain this investigation for a long time because of various reasons. I'll not say because of the financial reasons, because that was the government setup. Because of different reasons, that center couldn't sustain, and we are still looking forward for a public facility where this test can be carried out locally. So we are relying on the labs which are doing it for us, and obviously they are more cost involved in the whole procedure.
Because see how the problems get now wheel into wheel, because even if we do recommendation from a professional organization and we hit upon a method where everybody is tested for their thalassemia status, what next would still be the question which is haunting us. Sampath, for the next and the last case. Sampath.
No, madam, we have another one case also.
No, but you just go ahead with the third case, please.
Yes. Sir, as Dr. Arun just told, with the electrophoresis, waiting for the results, you can go with the indices and diagnose the thalassemia. Now we will go with this case. She is 29 years old, gravida 2 with one previous abortion. She has come at 21 weeks with a history of bone pains, joint pains on and off, and a history of jaundice 1 month prior. And she had been treatment for anemia on and off and underwent cholecystectomy for gallstones. That is 2 years back. With the history itself, you can come to the diagnosis, whether it is a hemoglobinopathy or whether it is a deficiency anemia. So I want Dr. Sarita to go with this case. How are you going to proceed with this? Dr. Sarita and Dr. Chirag. Dr. Sarita? Then Anahita can take up. She is also from Mumbai. Dr. Anahita?
Looking at the bilirubin, Dr. Sampath, and the very high retic count,
yes, ma'am.
I think this is probably, and I can see your picture there, which is showing probably a sickling. And that is the reason why the patient has the bony pains. So
yes,
thank you for giving us the final statement where the S is very, very high, 88%. And this in pregnancy, first of all, is sickle cell anemia is only common in certain parts of the country. Luckily, it is not that common. But I have managed quite a few in Mumbai because we have a very good hematology department and patients have come as referrals. And pregnancy in these women can be extremely treacherous, and they also are subject to extremely high morbidity as well as mortality. So we have to be very, very careful if we do see this kind of picture with a sickling on the peripheral smear. Please refer the patient immediately and involve a hematologist at a higher center.
Yes,
Chiragji, Dr. Chirag, I want to ask you that, see, you told the importance of history taking. So in this case, yes, there were a lot of pointers towards this in the history. So do you think the routine history taking, what are the 3 or 4 additional points that we as clinicians need to ask in order to avert this diagnostic dilemma, in your opinion?
So as I told you, for the blood loss particularly, from some place of the body. So particularly pregnant women are more susceptible to the epulis, pregnancy epulis and piles. So we need to rule out that. Worms is a very, very important thing which we are missing generally. So either deworming as a routine, or we should at least ask a proper history to the patient. And accept that family history for hemoglobinopathy, as we say. But from the part where I am practicing, we are doing HB electrophoresis for all patients. So for us, it is not like important part as far as history is concerned. We will do for all patients.
Excellent.
But,
yeah, please.
Yeah, but everywhere in India, it is not possible. So I think this is the right platform to start the initiative, that if FOGSI can help in places, as Dr. Arun told, that there is a very difficult situation, if something can be done by FOGSI to put
So
in
that
lab.
is, yeah, that's a great takeaway. Shikaji, I want you to again address the diagnostic dilemma. See, by looking at it, yeah, we all presume that it's iron and nutritional deficiency as how it was outlined right at the start. Then the least you should do is CBC and peripheral smear. So do you do this for all patients coming into the public setting? And how competent is the lab person to give you the reports which will not miss any such case by these two simple methodologies?
These two investigations are the minimum lot which is given to all the antenatals, because the 5 set of investigations, it includes the peripheral smear and CBC, which will catch 90% of the cases, which will differentiate them into the high risk group and the 90% low risk group, which includes iron deficiency anemia. So that will screen the 10% which will need further set of investigations, which are more complicated and costly. And these two basic investigations should be done in all. And if we are very careful in reading our CBC and careful look at the red cell indices, that gives a clear indication. That gives a clear indication of the peripheral smear and indices that which set of patients will require the next set of investigations.
So I think so far the conclusions are that, you know, at the minimal diagnostic dilemmas, if you want to avoid CBC and peripheral smear, we have to sensitize the clinicians to look at it more carefully so that it can be pointers towards the next step that they have to take. That's for sure. And Arunda, since the electrophoresis facility is not available, and Vatsla said that no, until I do the electrophoresis, I will not want to give the parental iron. What is your methodology? Do you always do a CBC peripheral smear and then go ahead giving the parental iron? Because visits are infrequent. The incidence of anemia, the severity is way too much, and you have very little time. Is there any harm in just empirically giving the parental iron in the interest of both the mother and the baby, and then you move forward with whatever diagnostic dilemmas you have with what little investigations you can do? What is your take on that, Arun?
Yeah, my take is when I'm limited by the number of investigations, I have to treat the patient as well. So I have been able to do the ferritin along with CRP. I'm aware that ferritin is also not a strong marker in presence of an inflammation, and that I try to cut it off by just doing an CRP. Wherever there's a rise in a CRP, I do not take ferritin as a right marker for iron deficiency. Then I have to go clinically as well. And as one of the panelists rightly said, in those cases, we try to reduce the dose of ferric carboxymaltose to 500 milligram or even less. But where we have the facility where we are getting the proven documentation of a low ferritin and a normal CRP, that gives us a confidence that we can at least load the patient in one dose of a total parental therapy of 1000 milligram and be assured that we are taking good care of iron deficiency, both for the mother and also for the inborn child that is she is carrying inside.
Yeah. Well, sir, now this is directly an opposite kind of a scenario. It's not microcytosis where we are confused about the iron deficiency and the thalassemia. It is peripheral smear is what everybody here seems to have done as a part of their basic diagnostic workup. And you find macrocytes and you find the hemoglobin only as 8 grams. And we're already, you know, at 28 weeks of pregnancy. What will your thinking process be in this case?
You're asking me?
No, Vatsla.
So since we're seeing macrocytes, we would, at the pregnant patient, we would think of maybe a dimorphic anemia. At least think of B12 and folic acid deficiency. So we could do her retic counts and look at the other peripheral smear. So if the retic counts are sort of increased or normal, or if the peripheral smear is showing hypersegmented WBCs, or if the platelet counts are low, goes more in favor of a B12 folic acid. And history-wise also, we can see if her diet is adequate or not, but most of the vegetarian people, if they're not taking adequate diet, may be deficient in B12 folic acid. So at least this much. And after this, maybe some other conditions which may also cause macrocytes like thyroid dysfunction or liver dysfunction. All those things would come later, but definitely this first.
So if it is macrocytosis, your thinking process will be along this line. Excellent. Now, Sarita and Anita, both of you, I want you to tell when you're getting, the hemoglobin electrophoresis, this, that, does your routine, a great profiling of all your metro patients include estimation of serum B12 and folate as well? Anita?
No, I don't do this routinely.
No, it's not required.
Okay. So, because many would, come with an automated, report with runs many pages inclusive of all these, and they'll keep quizzing us as to the normal range, as to what they have found in their own report, etc. So, Meeraji, do you have some of your patients already coming, even if you've not asked? They've just gone to some other practitioners and they have a whole load of reports and they're more anxious than you can imagine because these levels are shown one way or the other.
Hema, I may tell you one very important thing, that every patient is not of the same normative. Some of the patients are very poor and they come in masses when we are in the medical college, 30-40% sitting and a big OPD. So we cannot carry out all the investigations meticulously in all the patients. I agree with all the panelists that peripheral blood smear is the basic thing. CBC is the basic thing which we have to do before starting any treatment. Basic thing has to be carried out. Then we have not discussed one thing over it, and there is a deadly duo. One of the journals have very rightly advocated that apart from the B complex and the folic acid, we have to be very careful about the vitamin D, because vitamin D and this iron deficiency, they work just at the basic level when the reticulocyte count is being formed and the reticulocytes are formed and the nucleus is being deleted, and so that is a deadly duo. In these patients, apart from B complex and folic acid, we have to add vitamin D sometime, but we are not doing routinely vitamin D, B complex and folic acid. That is what I wanted to tell.
Right. So, can I have the concluding remarks from all my panelists? I'm going to stop slide share because, see, we are to walk on the path of Anemia Mukta Bharat. And we are walking and walking and walking and walking since the last 40 years, but have not reached the destination, right? So what is our thought process on how we are going to make this happen? Chiragji, starting with you.
My side, as you asked it, whether a lot of people are coming with B12 or D3 levels or not, where I am practicing, I have seen so many patients because they are much more aware. And they come up with about 70-80% of time they have low B12 and D3. So it is imperative that we actually supplement it. Suppose you don't get the report done, why not you supplement it? Because it is going to be necessary. And now the new supplements which are coming up, most of them have B12 along with it, or say D3 also with calcium.
So D3 has become lately, after the discussion and research process going on, D3 has become a part and parcel of the treatment of the anemia.
Yeah. So one point which is clear from Dr. Chirag's response is that, see, the diagnostic dilemmas, which is the focus of this panel, many a times there may be no access to actually do all these diagnostic parameters. But the way some people already come with that, and we recognize that the deficiencies are there. So pay attention to supplementing iron, folic acid, B12, vitamin D. It's a, we can call it a cocktail of something, because all of these in a nutritional anemia, all of these are any which way needed. Otherwise, your response is likely to be, definitely likely to be suboptimal.
So, madam, you select a supplement which contains a holistic range.
Yes.
And we are even forgetting B6, for example. Pyridoxine is one of the agents which is necessary throughout this cycle of development of hemoglobin. And
Sure.
sideroblastic anemia has been known to develop, which is responding to pyridoxine.
Because on one hand, not doing all the investigations and continuing to be in a dilemma. On the other hand, not paying attention to what is the wholesome supplement that you're giving and only focusing on iron. That's not to be done. Definitely, yeah. Point well taken, Vatsala.
So I definitely agree, because it's not that iron that is required for hemoglobin synthesis. So you have a whole lot of micronutrients, so that also needs to be supplemented. And it's not only just prescribing iron to the woman, go and take this tablet. We have to talk to her about the diet. The nutritional counseling is important, how to take iron, when to take iron, and how to avoid taking foods which are going to, the one which are going to interfere with absorption and which are going to facilitate absorption. So these things are also important, which we are missing. And the other problem in our country is chronic inflammation, anemia of chronic inflammation, which maybe we cannot tackle by only giving iron supplements.
Yeah, thank you, Vatsala. Even the WHO 2020, the guidelines as recently as April this year have said that micronutrient supplementation is an absolute must. So, Shikha, I want your response to Vatsala's statement that these little things we leave out. Do the clinicians, before declaring that she's not responding to iron, do they make sure of all these little instructions in your busy setting? Or are we failing our women there because we are not bridging that simple gap, and we are saying this, we are always in a pool of patients with anemia? Yeah.
No,
honest answer, Shikha.
We have counselors with us because we and our residents are very busy. So we send our antenatal patients for counseling, because the iron-rich diet basis, which will be the diet will be forming the main part of her for the whole 9 months. Maybe she's having regular visit, getting her iron tablets, she's coming or not. But if she has been properly counseled right through her pregnancy for a good nutritious diet, iron-rich diet, so that counseling is very mandatory, and we give time for this counseling also. Maybe it is not done by us, it is done by our counselors, and it is a part of the antenatal OPD schedule. Because we can prescribe iron in the parenteral oral form, we can give all the investigations, but the basis is what she eats and what habit she is following her right through her 9 months. So that must also be dealt with, even if we say we are very busy, but that should be part of the counseling of every antenatal woman.
Yeah. So whoever does it, but do it. Yes. So that's why, Arunda.
Yeah. My take would be, we must educate, we must treat, and the concept of family physician. If you say we are too busy, I think we just leaving the responsibility to someone else. We have to take the responsibility on our own shoulders and at least treat few of the patients. You cannot say we are too busy and run away from our decision of recognizing and treating a particular woman. So I must say collective decision, and the important role of family physician is always to be encouraged, and a dedicated awareness program has to be carried on in the school level, college level, so that people really come to know about the impact of anemia in today's context. As our President Alpesh rightly said, today everyone is aware of COVID. How? It is because of awareness. So we are just falling short of that awareness that makes us more anemic people into the society. I think we need to do more than what we are doing now. That's
okay. Okay, Sarita. Awareness, I think, all of us always knew that anemia is here to stay, and now we are very strongly changing our mindset that anemia hatao. Okay, so you are in a cushioned position because you can get any which test done for any of your patients, right? So or the diagnostic dilemmas that were described and prescribed today, what in your practice will still be a dilemma? What more you may want to still step up and do beyond the basics? Are there some refractory cases where you have to often refer them to a hematologist. That this is not looking all right.
Yes, madam, there are. There are, and I feel that whatever we do, some patients may not be compliant, some patients may not take iron, and some patients their absorption for some reason they're not able to absorb oral iron. I think that our parenteral iron has to a large extent solved this problem, and giving them parenteral iron is really very, very beneficial. But some refractory cases, I definitely do a physician's or a hematologist reference.
Great. Anita, before Sampath and Miraji close the session. Anita.
So I've listened to all the other panelists, and I have 2 or 3 little bits to add to what Dr. Arunda said. I think we have to look at a life stage approach. Start in adolescence, make sure she enters pregnancy with a good hemoglobin, and keep in mind that towards the end of her reproductive life, with the heavy menstrual bleeding and other problems, she's also going to suffer anemia. The second point I wanted to make was the government has to step in. If the government can work so hard to screen millions of people for COVID and ask for antigen tests and everything else, surely they can make available the basic and advanced investigations in places where needed. And the third point is, I would still be reluctant to jump to the more expensive tests because nutritional anemia will be the bulk of our patients.
Sure. In a wholesome way, you started also saying that nutritional anemia is the first thing that gets into your mind, and few simple step-up investigations is all that you will require to hit the target on how you will get her to the pink of her health. Now, Sampath, being the vice president-elect, and with your president having a very strong focus on doing more and doing better, what will be your support to FOGSI as your visionary leader has spoken? How much and how far?
Yes, madam. For all patients, definitely if you come with the anemia patient, as you told earlier, we have to do the peripheral smear and indices, and we have to differentiate. And for doing for advanced stress, electrophoresis, ferritin, TIBC, everything, but you should start the treatment. Still, we are having the patients of 3 grams hemoglobin. Till the results comes, if you are not going to start the treatment, again the patient may end up in APH and PPH. So the basic, as Anahita madam told, the basic investigation should be done, and the government should make it possible to do this basic investigation for all patients and institutional delivery. And another one point I want to tell is the anemia has to be corrected during adolescence itself. When a girl is 12 years, the hemoglobin should be 12 grams. Once the hemoglobin is corrected only, she should get married. Usually I will tell, when a girl is getting engaged, instead of giving gifts, we can give iron and folic acid to that girl until the marriage. At least the anemia will get corrected during this time. So we have to do a lot of basic things that to reach each rural and urban, whether rural or urban, even in the urban. The diet, lifestyle, what the diet they take may not be rich in iron. So iron deficiency anemia, nutritional anemia is common throughout everywhere. So it has to be done only by the counseling and the basic test. Thank you.
Yeah, thank you, Sampath.
Hema, can I ask you a question before you end?
Please. Yeah,
So,
I want to also place.
General,
Rishi, I also want to place 2 important innovative ideas that you have raised about the point of care with a non-invasive hemoglobinometer, which is coming from Israel into the Indian market very, very soon. And we will take support from the parent organization to have this made available everywhere, so that is one simple step. And your dream of somehow making the hemoglobin electrophoresis also very, very widely available, because before Preeti finishes her tenure as a Safe Motherhood Committee chairman, we should very proudly be saying mothers in this country are safe from at least basic problems such as anemia. That is the least we owe to them, and that is what we must do. And I will invite Rishikesh's comments and the thought process, which we are always ready to support. And after that, I will give the grand closure of this Grand Anemia Conclave to our grand lady, Meera Agnihotri ji, who has joined us with IHW to take the shapath or the resolve to walk on the path of Anemia Mukta Bharat. Rishikesh first.
No, I just wanted to say when I was Secretary General, you had got some person where there was a supplement we were trying to think of which would cover all the things.
Yes.
Like a supplement, the energy bar kind of thing, which can be given, which will give the protein supplement, the calcium, the vitamin D, the iron. Is there something in the market like that which we can then push? Because what the problem is that people are poor. So at least if they get that supplement, iodization, iodine also.
At
So
the moment, that mega idea,
Ramban hai kya kuch? Ramban hai?
That mega idea boiled down to giving only chickpeas, the peanuts and the jaggery, very rich in iron and protein. So every school program, anywhere we went, one chickpea we used to supply. We got millions of tons from Pune, and that was a quick fix. But there are some nutritional organizations which are ready to handhold to fortify and make it like a junk health. It looks like a junk food, but it's a healthy food. So it is very appealing to the generation next to get this on. So that is why we need to think out of the box, and at our level, clinical level, whatever we are doing, we're doing, but at the consumer level, we need to also address that. So we will have this reminder idea back in its place, and we will do something about it. Arunda, before Meeraji closes. Yeah.
I am just trying to push in one idea that I have been practicing.
Uh-huh.
All adolescent girls that come to my clinic,
Mm-hmm.
I prescribe them iron tablet for 30 years. Then the parents started asking me, why for 30 years? And that's how we can intimate them the importance of iron for the rest of their life. And this has really made a lot of effect in my society.
Okay, great. So
Very
each of the innovative ideas taken on board, and will collectively work towards making India anemia free. Meeraji.
Hema, it was a wonderful discussion. I really enjoyed it and added very many things to my mind. But I have got only 2 or 3 points to tell. One, most important thing that our graduates, postgraduates, and the doctors who are practicing, we have to change our mindset. When I was a teacher earlier, 20 years back, now today, and 10 years back, the things are changing like anything. These research projects which are going on nutrition in pregnancy. Earlier, all the students must be told the development of the reticulocyte, how it is coming from the bone marrow, what is the involvement of the spleen, how it is coming to the circulation, what is the place of folic acid in development, what is the place of B12 in development, and what is the place of vitamin D in the development of the RBC. Unless we know this thing, we will not be able to prescribe it. That is one thing. We must know the place where it is entering, how the mature cells are coming, how they are immature, what is that is the deadline. One thing. Second thing, we must always be having a holistic approach, as Rishi is telling. We have to know that now anemia has to be treated with iron. I agree with Sampat. When she was there in the adolescent committee, she was with us at Kanpur, and she must be remembering very well. We had a long, big campaign. Kiran Pandey was also a part of it. And then we have introduced 12 by 12, that we were examining all the adolescent girls, that they must have the hemoglobin 12. Sampat must be remembering it. It was a huge meeting, and all school students, they were imbibed what is the role of the iron. Third thing, while we are prescribing treatment, we have to know our limitations. If I'm in a very primary health center where the facility is not existing, then telling that unless electrophoresis is done, electric this is done, we have to treat the patient because they are dying. We have to do something. And then we have to decide blood, parenteral, intravenous, intramuscular, or oral therapy, depending upon the time which is with us for the delivery. That is what I wanted to tell. And only thing which is needed for it, I come once again, that is training and awareness program. That is what.
Thank you so much, ma'am. Preeti, thank you very, very much for bringing us again together to really think and rethink and try and execute to the best possible impact that our thought process can have in translating it to action. And I really appreciate that Rishikesh is already on a planning stage for his year, and he has sat through this entire anemia panel to consolidate his thoughts on what better we can do in a collaborative fashion. So I have made a note of that, Rishi. There is a lot more of finer nuances which we can do as a quick fix. You know, where we can turn the scenario around. And my very beloved friends, Meera, Vinita, and the rest who are there as a battalion of champions with Preeti and Lakshmi and Jaiswalji and all of you who are here to support us, not only in consolidating our thought process, but actually putting things into action. And we will soon see that girls and women and the entire community in India is soon in its pink of health. Thank you very much for the opportunity.
Meera madam, thank you madam for that adolescent work in the Kanpur.
Thank you. It was a wonderful program.
Then throughout.
Thank you.
Thank you, everyone.
Preeti nahi dikh rahi. I can't see Preeti.
Madam, I'm there. Thank you so much, ma'am. I'm there.
Preeti learned a lot. Lot of things I learned today.
Thank you so much.
I feel like just give you blessings and blessings. Preeti and where is Alpesh? They have done wonderful job. Preeti, आज के program ने undergraduate से लेकर supremes तक like हमारा ऋषि, मतलब he is being energized and he will do something. We are
yes ma'am, it is true. बहुत सारे undergraduates and postgraduates भी आज link पे जुड़े हुए हैं.
तो मुझे लगता है कि वो जरूर सबसे पहले रेटिकुलोसाइट का डेवलपमेंट पढ़ेंगे तभी ट्रीटमेंट लिखेंगे. Thank you very much, Preeti.
Thank you so much.
With the least amount of interactions with my panelists before the panel, and no match fixing, and they did a brilliant job. So thank you so much.
Thank you.
Bye everyone.
Thank you so much.
Bye.
Let us extend the vote of thanks, Dr. Pai. Just wait for 5 minutes. Sangeeta, please carry on.
Thank you, respected moderators, experts, and panelists for the power-packed brainstorming session. And they will not sleep till every mother becomes anemia-free. So we have a few questions in the chat box. Ma'am, Dr. Hema, ma'am, the first question is to you. What is the role of premarital screening for hemoglobinopathies considering the social fabric of India? Can we resort to it, or we have to shift our focus towards the schools and colleges? So ma'am, what is your take on that?
No, I think ideally everybody before marriage should know their status whether on hemoglobinopathies. That's the dream. We are taking one step at a time, because there are many hematologists with whom we have had a dialogue, and they're very saddened that we have not taken this hemoglobinopathy issue on a war footing, and we definitely need to and want to do something about it. So yes, before getting into the linkage of marriage, each and every girl, if she knows her status of the hemoglobin and hemoglobinopathies, it is the ideal scenario.
Especially in our area, Hema, Vidarbha is very much towards sickle cell disease.
Yes, Lakshmi.
So we really need to do these hemoglobinopathies in across all the schools for all the adolescent girls. But the problem is of cost, because whenever we approach any farmer, they are willing to do the hemoglobin. But when it comes to do sickle cell, then definitely the cost increases. So, I mean, again, Rishikesh will think of some out of the box idea, because it's a huge task for millions of adolescent girls, and doing hemoglobinopathy. Hemoglobin, everyone is ready to do.
That's right. Yeah. So it's important. The importance has at least been recognized and underlined, but we will work our way around it to
especially
something
in high risk areas who are more prone for sickle and cell. At least we should focus on those areas.
Sure.
You know what, I feel that one idea I suddenly thought is this insurance companies that are there now, we all take insurance, they should earmark some amount of money for curative purpose. So every year, because they collect premiums, the percentage of that premium, how that there's a CSR 5% compulsory. So government should make insurance companies spend 5% on compulsory, preventive aspects of health.
Right.
So, good idea.
we come to the closure of a wonderful interactive session, and we have lots of questions, but since the paucity of time is there, so we would like to take this question on 30th, which is another session we'll be having on Anemia Conclave. So we will add these questions there and continue the session. So thank you very much, Hema ma'am, Sampath ma'am, Meera ma'am, and all the wonderful panelists, Dr. Lakshmi ma'am, Pai sir, for your wonderful inputs. And we go ahead to close this session, but before that, there's a video of personal invitation by Dr. Preeti. So everybody should join on 30th. Have a look at it, sir.
Namaskar. I myself, Dr. Preeti Kumar, would like to welcome you all to virtual Grand Anemia Conclave 2020, which is scheduled on 27th November and 30th November from 4 to 6 p.m. It is organized by FOGSI and Safe Motherhood Committee under the leadership of our FOGSI President, Dr. Alpesh Gandhi, Dr. Jaideep Tank, and many FOGSI leaders support the mission. We understand that 26th November is Iron Deficiency Day, and it's a wake-up call for all of us. Anemia Mukt Bharat, the mission and vision of our Honorable Prime Minister, definitely addresses some of the issues of failure of the programs held in the past. Today, FOGSI joined hands to achieve the target of Anemia Mukt Bharat of reducing the incidence of anemia in pregnant females to about 30 million pregnant females would be benefited with this mission. Grand Anemia Conclave addresses the issues of diagnostic dilemmas on 27th of November and clearing the concepts of management on 30th of November. And we would like to thank Lupin for supporting the endeavor. Do join us on 27th and 30th November at 4 to 6 p.m. sharp, because we need to test, treat, and talk anemia. Thank you so much.
That's it. We are going to test, treat, and talk anemia again on 30th. But I request all the dignitaries here to put on their gallery view, because I'm going to propose a vote of thanks to each one of you for being so gracious enough to be here, and we can have a picture of that. But please do not go. We have one more interesting thing, which I always say for the last. SMC committee के द्वारा एक बहुत ही interesting video बनाया गया है. Pai sir, आपको जरूर देखना, and I'm not going to let you go before that, sir. So here it is. I'm going to propose a vote of thanks. And before that, I want to say one thing, that thank you word not only speaks for the courtesy, but also for the spirituality, because speaks of the gratitude for each individual, visible or invisible, who has contributed to the completion of this event. So thank you, everybody. I deem it a great honor to propose a vote of thanks today, for the event is mega event, and there are mega people here. All the inspirational figures are here for me. And first and foremost, to the Almighty for the success of this program. More than 1,000 people were here to hear you all. For the blessings of our teachers, Dr. Chandravati ma'am, Dr. Meera Agnihotri madam, to our president, Dr. Alpesh sir, who despite being unwell, graced the occasion so kindly. Dr. Jaideep Tank sir, Dr. Atul Ganatra sir, who have constantly guided and supported each of our activities. Dr. Preeti Kumar, of course, she's a great mentor. Her commitment and her sheer hard work and dedication has a positive impact in the life of every mother and each of one of us. Our chairpersons, Dr. Nirja Batla ma'am, Dr. SPSR ma'am, for their valuable inputs. And substance of any conference are the good speakers and the good moderators. And we have had wonderful ones today, because they have put their ideas and balanced it with such simple facts, so that we know what we are going to talk about in future. And today, Dr. Jaideep Tank sir, Dr. Girija Vak ma'am, and Dr. Tripathi sir, thank you very much for being here. I thank Dr. Pai sir again and again for sharing his views so candidly and so enthusiastically. I'm sure we are going to make a great team with you, sir. Panels are only interesting when there is a lot of sharing of knowledge, maybe a brick and bats, but still it's good. Thank you, Hema ma'am, Dr. Sampath ma'am, once again for the excellent panel No pre-questions asked, no pre-preparations done, and everybody came out with honest opinions. And the wonderful panelists, Sarita ma'am, Dr. Anahita Chauhan madam, Dr. Arun Barwa sir, Dr. Chirag Amin sir, and Dr. Shikha. Thank you for being here. And finally, my comrades in arms, Dr. Sangeeta, Rajul, Dr. Parulji, Aparna, Vidya, Bhavna, Anita, Vinita, Amrita. You can see the number of team, we were playing behind the scenes for each one of you, who fitted the jigsaw puzzles with me. We tried through the nights to give you one good show, good knowledge, good sharing of event. Thank you to our academic partner, Lupin, for such a strong technical support. And finally, my dear delegates, without your presence, all this would be a total waste. And my heartfelt thanks to each one of you for being here. So, I leave you all with half of one quote from Martin Luther King, which I feel embodies the very thought which drives each member of the Safe Motherhood Committee, that whenever an individual has not started living until he rises above the confines of his individualistic concerns. We have risen today above what we're thinking for ourselves. We are thinking of the world, we are thinking of eradicating so many things, and we have the future visions. So do not forget to log in on 30th November at 4 p.m. and we'll be there. So let us watch a beautiful video. Am I audible? Yes,
Yes.
I am.
Yes.
I am audible. So we are going to watch a beautiful video named Ma, that is March Against Anemia, done by beautiful Safe Motherhood Committee members. So enjoy and thank you for being here. Thank you very much, sir.
Thanks a lot, everyone.
Thank you.
Namaste.
Thank you.
This was wonderful.
Thank you so much.
Thank you.
Let's all march against anemia on 30th once again. Thank you very much.
Thank you so much. Thank you, Dr. Hema. Thank you, ma'am. Thank you, Dr. Pai sir and all the team. You rocked the show. Thank you so much. Thank you, everyone.
Bye-bye.
Bye-bye.
Bye-bye. Bye-bye. Bye-bye. Wonderful program. Wonderful.
Bye, Madam Meera.
Thank you.
Bye, everyone.
Bye.